the committee have organized. This Zumba or whatever. I have never done it in my life. I don't intend to start now, and we'll see. I also apologize for the cameras because I am going to be walking a lot, so you have to follow me. It's the only way I keep interaction. So that's where I come from, Dartford, Down Valley Hospital. That's the view of our hospital. It was one of the first PFIs, the Public Finance Initiative. It was opened in 2000, and it looks like it's been opened in 23 years ago. But it's a wonderful place. It delivers just over 5,000 babies a year, and I've been there for about 13 years. I've been a consultant for 20. I've been doing obs and gynae for 30 years. And in that time, I've developed an interest, a huge interest in fetal monitoring. As was during my introduction, I do a lot of medical legal work. I recently did an audit of 20 years practice of medical legal work, and of my 1,800 cases, about 500 were pure cerebral palsy or intrauterine death, and that involves the forensic examination of the cases, looking at the CTGs, and then sitting in conference with a neuroradiologist, a neonatologist, a pediatric neurologist, and all sorts of other experts to look at and see what happened to the baby, why it happened, and why did we see what we saw. And in that time, I evolved this realization that nice guidance, which was pattern recognition, really didn't solve the answer, didn't tell us what was going on. And not only did it not tell us what was going on, it also was looking backwards. So you're always reacting to what had already happened, rather than where are we now and where should we go? How long has this baby got? Is it fit for labor? Is it fit for pregnancy? Do I have 1 hour, 2 hours, 3 hours, 4 hours? And so the whole point is that you can individualize the care and you can anticipate where you're going. So that's a little bit about me. A little bit more about me is coming here was a huge honor because my great-great-great-grandfather, Reverend George Sorday, was a Methodist missionary. And in 1904, in Mysore, he founded the CSI Holsworth Memorial Hospital. And what I didn't realize until I went there was that, by some coincidence, the maternity ward is named after him. So clearly, I was destined to do obs and gynae from I can't even think what kind of embryo I was at that in 1904, but from a very long time. So my family have had a link to this area to southern India for a long time, and in fact, my wife's family come from Bangalore. And so I frequently not frequently come here, but I've been to Bangalore and around for many times, and I love coming here. So what are we going to do? Well, it is interactive. Now, normally, I have about this group, maybe that one. So I don't normally have this huge number of people. I like a little bit of interaction. So if those of you who are not too shy, if I ask a question, please feel free. There are no... and also, if you have a question, please, we have time. And if you have a question, there'll be another 100 people who've got the same question but just don't have the confidence to ask it. So if you've got a question, I'm very happy to take a question, say, excuse me, I don't understand, that's absolutely fine. This is your session, not mine. I do this session every month to our midwives and doctors, and it's always an interactive session. So when I was offered to come here, I said, I will happily do this session, but on one condition, not on Zoom, because I need to see people, I need to get the feedback. So we're going to do the physiology and pathophysiology, the bones of the whole concept of fetal monitoring. We're going to talk about the 4 features: baseline variability, accelerations and decelerations, the standard stuff that you know, the fetal acid-base status, physiological interpretation, the whole point that you're here, and then we'll do case studies. We'll do as many case studies as you have time for, or we have time for. If we have I've got 150 with me, but we're not going to do 150, I promise. I've selected a few to go through. So let's crack on. If we look at this, have a look. What do you see? Do you need any more information? Now, if you're going to use NICE or FIGO, you have to wait. You can't act on what you see there. But with physiological interpretation, I take one look at that, and I see 5 things. Anybody want to shout out anything that you see?
Maternal pulse.
Maternal pulse is 60.
60, yeah.
Is 60. So it's been written, so we know the maternal pulse is 60. Anything else? Anything obvious? I don't ask difficult questions. You don't need to know the risks. I'm not telling you any risks. I want you to tell me what you see. You see a deceleration. Excellent. How many? 2 decelerations or 2 heartbeats? Ah,
Twins.
you were saying 2 decelerations, weren't you? 2 heartbeats, yeah? Twins. Ah. Is it twins, though? Or is it the same baby being monitored twice? Yeah, it's a twin monitor. And in fact, I will give you a little bit of information. Monochorionic twins at 33 weeks. So we've got 1 deceleration, same baby being monitored. What else? What's the baseline, roughly? I mean, I know we haven't got one out. We've only got 2 minutes.
We can't determine the baseline.
But give a guess.
140, 150.
Yeah, or maybe if you go look at the top, it could be 160. It's high. Probably. I'm not saying definitely.
Yeah.
Probably. What's the variability?
Variability.
The variability is 0. Okay, there is no variability. So you've got a deceleration, you've got 1 twin being monitored. What's causing that deceleration? There is only one thing that can cause that deceleration. Cord compression. Okay? Straight down, straight up, that is cord compression. I look at that trace and I go, hypoxic, cord compression, antenatal, Cat 1. No steroids, no MagSalve, deliver. I do not need any more than 2 minutes. Now, you may say that's a little bit excessive, and okay, it's an extreme example. However, the midwife wrote, unable to, CTG difficult to, inconclusive, very difficult to monitor babies. The registrar wrote the same thing, this baby died. And her twin sister, because she's monochorionic twins, has got autism. And we'll talk about that, and that there's a very strong evolving pattern of prolonged partial hypoxia causing autism. And when you've got monochorionic twins that share a placental circulation, when one twin dies, the blood pressure in that twin goes to 0, the blood from the surviving twin goes into the dead twin, and the cardiovascular instability in the surviving twin, which in this twin lasted 45 minutes. So not long enough to cause brain damage that you can see, but long enough to cause autism, we think. Difficult to prove. There have been court cases in Ireland where one child won €6 million for autism alone based on prolonged partial hypoxia. Now, why do I show this slide right at the very beginning? Well, I show this slide because when I was doing this as a medical legal case, I literally had tears in my eyes of despair that this poor baby had to suffer, eventually died, because people were relying on pattern recognition. They couldn't understand the pattern. There was no pattern, but physiologically it became very clear, very obvious what's going on. This is core compression at 33 weeks. That's oligohydramnios. That is placental failure. That equals you need to deliver. Now, so that's just one example. There'll be other examples as we go through the session. So let's go to back to university, back to the physiology and pathophysiology and the anatomy. So I had one of those eureka moments. I was thinking, how can I explain to people what is it that I look at a trace and I think, I know what's going on. Why do I know what's going on? Because I suddenly realized that all a baby wants to do is keep its blood pressure stable. And if you think about it, if you break down the human body into its absolute bare minimum, the bare bones, what are we? At the end of the day, all we are is a brain on sticks, nothing else. We are a brain on sticks, and everything else that's added on is designed to feed the brain. So the legs to go to the food, the hands to get the food, and so on and so forth. So all we are is a brain on sticks. And all a baby is the same thing. And the whole body is a slave to the brain. So if you affect the brain by upsetting the blood pressure, the heart will regulate itself in order to keep the brain fed. And that's all it is. We'll come back to that, and it's very, very pertinent when we talk about core compression and why the core compression looks exactly as it does. So, going back to the anatomy and the physiology, so as you know, in the uterus, the placenta is the baby's lungs. There is one umbilical vein that goes from the placenta to the baby, beg your pardon. And then the baby has got two umbilical arteries that go from the baby to the mother. The placenta is a low-pressure system. Very important to remember, low-pressure system, because when it comes to core compression, that low-pressure system really kicks in. The umbilical vein is very big, very thin, and it's easily compressed. The umbilical arteries are small, very muscular, and they compress very hard, and they spring back very quickly. So there's a differential there as well. But the important factor there is that the placenta is a low-pressure system. The heart, which pumps the blood around, is a muscle. I'm stating the obvious. But what is important to remember is that, like the uterus, the placental flow in the uterus only occurs when the uterus is relaxed. The more it contracts, the less the placenta flows. In the heart, it's exactly the same thing. The more the heart contracts, the less oxygen it gets, and the more the heart contracts, the more oxygen it needs. Therefore, this uncomplicated fetal tachycardia that we talk about is nonsense. The baby will get tired. The heart is using up all its reserves, and it's not getting enough oxygen. So we need to make sure that the heart has enough time to relax, just like the uterus has enough time to relax. So we need to be mindful of that. If you take the heart out of the body, it will beat at 40 beats per minute. It has an intrinsic rate. But the rate is altered in the human being by various systems. The somatic nervous system, which is what's happening to me at the moment. And what will happen to you when you do your Zumba, you'll get your somatic nervous system in, it will put your heart rate up. That's what we look for, fetal accelerations, and it's a very helpful sign. Behind that, we have the autonomic nervous system. We have the parasympathetic, the rest, relaxation, and restore, followed by the sympathetic, the fight, flight, and freeze. Sympathetic, followed by the parasympathetic, wrong way around, sorry, but I apologize. So sympathetic, fight, flight, and freeze, the parasympathetic, rest, relaxation, and restore. The autonomic nervous system, the parasympathetic and the sympathetic are in continual battle, with the parasympathetic pushing the heart rate down and the sympathetic pushing the heart rate up. That battle, the sympathetic, parasympathetic, is the variability. And it is that piece of information from the CTG that is the most vital piece of information. You may remember from when Raji was doing her CTG session, I said I would section there at 3 o'clock. That's when the variability went completely. I said that was the time at which I was concerned. Why is the variability most important? Well, you need your receptors to recognize what's going on. You need the afferent fibers to feed the brain. You need the brain to compute. You need the efferent fibers to go to the heart. And you need the heart to respond. All that circuit, those 5 points, have to be fully functioning in order for you to have variability. So if you don't have variability, something in there is not working. But if you do, then the whole thing is working, which is really good news. The other thing to remember about the sympathetic and parasympathetic is they do not develop at the same rate. The sympathetic nervous system develops first, okay? So, which is not surprising, because you're not going to develop your rest, relaxation, restore to get life going. You need to put your sympathetic nervous system in. It's going to fire up the baby. The baby's going to come to life, and your heart rate's going to run. And it's going to run high. It's going to run at 160, 170, maybe 180, because that's pure sympathetic. When you get to about 26, 28 weeks, the parasympathetic kicks in. And so that's, from then on, the baseline rate is going to drop, 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 drop. So one aspect already about physiological interpretation is that you can work out where the heart rate should be if you know what it is at 28, 30 weeks, at 38, 40 weeks, it's got to be lower. So there is some method and some benefit in doing CTGs at 26, 27, 28 weeks, because you get a rough baseline of where the baby lies, and you would anticipate that the baby will drop. Now in Kent, we're doing a regional CTG monitoring guideline, and within it, which is going to be physiological, we're also going to have upper limits which change for the gestation. So yes, the rough range is 110 to 160, but once you get to 40 weeks, it's probably going to be 150, and when you get to 41 weeks, it's going to be 140 as the upper limit, because we recognize that the baseline should drop. The other thing I forgot to say about the beauty of physiological interpretation, especially maybe in India where you're going to use intermittent auscultation more, is that you can use physiological interpretation to understand intermittent auscultation. Because in the UK, there's a movement called intelligent auscultation. You understand the physiology. When you're listening, you're thinking, and you're saying to yourself, what is happening to the baby? What is the baby telling me? What is its condition? Is it happy? Is it sad? What's the uterus like? And you can put all that together without even a CTG if you understand what's going on. So the parasympathetic and the sympathetic are in battle, and the battle, it creates the variability, and the variability is the most important thing. Now, as I said at the beginning, the heart gets its information from receptors, and there are two types of receptors, which Raju hinted at, which is the baroreceptors and the chemoreceptors. Now, baroreceptors are located in the carotid artery, which is very sensible because, as I said, the whole body is a slave to the brain, and the brain wants its blood supply 24/7. And as soon as there's some alteration in the blood flow, it's going to react instantly. So if the blood pressure drops, then the heart rate's going to go up. Instantaneous. If, however, the blood pressure goes up, which in the fetus will be with head compression or cord compression, then the baroreceptors are conditioned to think that high blood pressure means I'm going to blow a gasket. My blood vessels are going to burst in my brain. It doesn't realize that it's actually the skull being squeezed. And so it protects the brain by dropping its heart rate. That is a baroreceptor response. So you have two baroreceptor responses. One is core compression, and one is head compression. They are both pure physiology. There is nothing abnormal from a baroreceptor response. So in my unit, we don't call them decelerations, early, late, or variables. We call them what they are. They are baroreceptors. Then they usually say head or cord. But it makes it very clear that we're not concerned about what's going on to the baby. We know the baby's fine, but the environment may be the issue. So baroreceptors, instantaneous response, synchronous response, and the bigger the hit, the bigger the contraction, the bigger the deceleration. It will mimic the influence of the contraction. So those are pressure receptors, baroreceptors. The other receptors are chemoreceptors, and they respond to changes in hydrogen ions, carbon dioxide, whatever chemical you like. But usually carbon dioxide and hydrogen ions are the ones we talk about. And they are slower to respond. Now, both baroreceptors and chemoreceptors cause an increase in parasympathetic influence. They drop the heart rate. With chemoreceptors, there are two types where it is a delayed response because the chemicals build up in the periphery and then wash to the receptors, and then the receptors respond. By delay, we're talking milliseconds or half a second, but it is going to be after the event. And there are two ways that the chemoreceptors can cause their effect. One is to cause a pure parasympathetic influence after the contraction. So you've got your contraction, and then you've got your deceleration. And that's an isolated deceleration, usually in early labor or mid-labor. Or if you've got late labor, second stage, or head compression, you can have the head compression, which is baroreceptor. Now, normally that would recover, but if you've got chemoreceptor as well, then you've got the delayed recovery, what we call the tick. So you've got your deceleration, which is synchronous, and your recovery, which takes longer. So that is a chemoreceptor influence, and that is pathophysiological. So there is some pathology going on here, which is telling you that the baby is not 100% happy, but depending on everything else, in other words, what's the baseline, what's the variability, then you may be okay. And you'll hear me say that again. I may ask you, is this baby okay? And I'll ask you two questions. What's the baseline? What's the variability? Those are the two questions that you need to ask yourself again and again and again. If ever you're in doubt whether the baby is healthy or not, just ask yourself that question. What's the baseline? And is it appropriate for the gestation or the stage in labor? What's the variability? Is it reasonable? Yes or no? So we've got the baroreceptors, the chemoreceptors, but there's other controls of the fetal heart. There is maternal stress. If you've got a mother who comes in and is in absolute agony and stressed and anxious, and her adrenaline and cortisol is off the scale, then that is going to cross the placenta. And that is going to upset that baby's heart rate all over the shop. I remember once, very early in my career, this woman came in literally bouncing off the walls and the ceiling in such agony and distress. We managed to get a CTG, and it looked like the baby was having awful decelerations. And I said, look, just get the epidural in, calm her down, and let's do it again. We put an epidural in, she was completely calm, baby's heart rate was absolutely fine. And in fact, the decelerations were back to accelerations because of the stress of the adrenaline. So very potent. If you're not sure, calm the mother down by whatever means necessary, and then reassess the baby. Drugs. Multiple drugs. I mean, I think the more drugs we use in labor and pregnancy, the more we realize it affects the variability. Certainly, pethidine, methyl-dopa, labetalol, all of those have been well known, well recorded, to reduce the variability of the babies. None should reduce the baseline except perhaps pethidine, because it calms the mother down, and so our heart rate goes down, the baby's heart rate goes down. So pethidine will certainly, methyl-dopa. Steroids, I don't know how many of you are familiar with the effect that beta-methasone and dexamethasone can have on a preterm baby, but basically, you're putting that baby into an immense Zen state, and it's just, It's completely chill. It goes to sleep. It's a very happy sleep, but it makes all of us uber anxious because the heart rate is flat. And I mean flat. And so if you've given steroids and you've then got an abnormal CTG, what are you going to do? Section. Don't do it. Okay? Ask yourself, why did you give the steroids? And if you gave it for a spurious reason like twins or whatever or so on, or just SGA but not IUGR, so small for gestational age but otherwise completely fine, and you've given steroids and the baby goes to sleep, that effect will last 5 days. 5 to 7 days. And the baby will wake up probably with a hell of a hangover and be very upset with you. But it will wake up and it'll be absolutely fine. If you Google steroid effects on CTGs, you'll get loads of papers. It's so, so important because I've got a case which I can show you later if I'm sure we'll have time, where in my unit a baby was delivered at 29 weeks because my colleagues were not aware of this effect. And in fact, I was the only one in the unit because I have a special interest, and nobody was aware. So if you talk about medical legally, it would have been okay because nobody else knew. But you should know. So steroid effect, very important. Alcohol. We talked about alcohol earlier in the antenatal screening. It's fortunately very rare in my area that women drink that heavily in pregnancy. But if the mother's drunk, the baby will be drunk. And the CTG will demonstrate an undulating, heart-sinking trace, which you just want to go, oh my gosh, I've got to get the baby out. Don't. Sober the mother up, baby will sober up, the trace will improve. I know that there's a lot of talk about medical legal issues here. What I try to practice and teach is defendable medicine, not defensive medicine. It's very different. Defensive is bad practice. That's section them all, whatever. But defendable medicine means you can protect yourself, you can defend, you can do something completely maverick because there's a physiological basis behind it. And so as long as your documentation is good and you can back yourself up with some papers or some common sense, then you're fine. And generally, if the CTG doesn't deteriorate, why deliver? Wait until it gets worse. I've done so many medical legal cases where I say, they spent 5 hours deciding to do a cesarean section. That was way too long. But guess what? The trace didn't deteriorate. So the 5 hours had no effect on the outcome because the trace was stable. So conversely, if you don't need to do a cesarean and you're thinking, but the trace isn't good, so well, look, if the trace deteriorates, in other words, if the baseline goes up, the variability goes down, if there are decelerations, then I'll deliver you. But if it's just a flat trace, I may sit and wait.
Mark, can I just...
Yeah, loud.
Yeah, in that scenario with the steroid, if it was given on a baby with FGR and abnormal Doppler,
then you deliver.
And then you're given,
That's what I'm saying. The case I had was a young girl who was HIV positive, who had a previous SGA baby on the 5th centile. This baby was on the 2nd centile, symmetrical, normal Dopplers, normal Lycor. They gave steroids, to which I went around and slapped them, said, don't give steroids next time. So it's a different situation. That's what I'm saying. If you've got a dodgy baby, you've got no option but to deliver, and I'd say you're a fool not to. But if your baby was actually sitting there quite happily, small, then and in our unit, the sonographers can't get into their heads that the estimated fetal weight takes in leg length. And if you've got a baby that is destined to be the next Michael Jordan, it's going to be LGA, because the leg length is going to be off the 95th centile. But equally, if you've got a baby that's going to be very small, with short femurs, it's going to be SGA, because the EFW is going to be low. So you've got to understand that. Pyrexia. Pyrexia is obviously puts our heart rates up, puts the baby's heart rate up. And if you want to look really clever to mum, and you see the baby's heart rate go up suddenly, say, I'll take your temperature, not now, but in an hour's time, and I bet you it'll be up. Because usually the baby's heart rate goes up an hour before mum's temperature goes up. And the last control of fetal heart rate is, of course, the baby itself. Labor is a marathon, okay? You're putting this baby on a treadmill, and you're not going to let the baby off that treadmill until it delivers. Therefore, unless you have done something to change the environment, to slow down the contractions, to improve mum's condition, there's only one direction that heart rate goes, and that is up. So in labor, you would expect the fetal heart rate to go up and up and up and up and up. And it's a sign of the times that 10, 15 years ago, midwives used to come to me and say, Mark, can you have a look at the trace? The baseline's gone up. Now they come to me and say, Mark, can you have a look at the trace? The baby's not responding. It's not putting its heart rate up. I'm concerned. We've got the Synto up. She's contracting 5 and 10. The baseline's still 130. So there's an understanding that you should expect the baby's heart rate to go up, and it should not go down unless you have changed the environment. And again, you hear me state several times about changing the intrauterine environment. It's all about the baby and the environment. Have you got a healthy baby in a hostile environment, a healthy baby in a healthy environment, or an unhealthy baby in a hostile environment? So you're trying to tease that out. What is the baby saying to you? Is it waving or is it drowning? So, labor is stressful, and the baseline rate will always increase before you get hypoxic changing on CTG. So you'll get a rise in the baseline. There are different parameters. Some units say 10%. NICE says 20 beats per minute. You pay your money, take your choice. I don't think it really matters. As long as you look at the rest of the situation, you take in the mum's condition, and you look, where's the baseline, what's the variability, where are we going, how many centimeters are we? Take everything into consideration. So the 4 features. You're very familiar with these, but I will go through them again, just for the sake of it, because I think it's always nothing. Repetition is one of my mottos, and you'll hear, those of you who are paying attention, I might test you at the end and say, how many times have I said X and Y? Because I do tend to repeat myself intentionally. So the baseline rate, as we said, it reduces with increasing gestation because of increasing parasympathetic influence. So important to understand that. Simple concept. Because you get a woman who comes in for induction, not at the 39 weeks, at 41 weeks, let's say.
39.
Can't be in your unit then. But let's say 41 weeks, even at 39 weeks. And she comes in and she's got a heart rate of 155. And you go, oh, that's within the normal range. But then as you take a step back and say, no, hang on a second, you're 41 weeks. Your baby shouldn't be at 155. That's too high. Only 3 things cause the fetal heart rate to go up. Infection, maternal stress, fetal stress. That's it. Another thing that I hope you'll take away from the session is I like to break it down to very simple things. 2 things called baroreceptor, head and cord. 3 things cause the heart rate to go up. Maternal stress, fetal stress, infection. That's it. I try not to use the S word, sepsis. Because in my hospital, there are posters that say sepsis kills. And when mothers hear that their baby had sepsis, they think my baby nearly died. I'm like, yeah, it's a bit of choreo, get over it, it's fine. Yeah, baby will be fine. So I try not to use the S word. So infection. So infection, maternal stress, and fetal stress. So if she comes in at 41 weeks or 39 weeks for induction, mum might be stressed because she's very anxious. So it's not surprising that the heart rate could be up. And if you do mum's pulse and it's 110, then guess what? Give her a cup of tea, chill her out, she'll be fine, and hopefully you will expect the baseline to come down once she's calmed down a bit. So hopefully that. So baseline rate. Variability, I call it the bandwidth. And we had an excellent example this morning, and it's the battle of the sympathetic and the parasympathetic. The most important feature of the whole trace is the variability. Look at it, determine it, and make sure you've got cycling. Accelerations, the definition, increase of 15 by at least 15 beats. My little take on it is if you have to count the 15, doesn't count. It needs to give you a warm feeling inside that this baby is very active, very happy, but if you have to count it, it ain't there. I've been saying it for a lot of years, and people still say, look, 15. Decelerations, opposite. A reduction of 15 for 15. However, and this is however that it only applies if the variability is definitely below 5 and preferably below 3. You can have shallow decels of 10 beats or so, and they are extremely ominous. I hear people say, oh, it's only a shallow deceleration, that doesn't matter. I go, well, so what's my question? What's the answer? I have 2 questions. If I hear it's a shallow deceleration, what are my 2 questions? What's the baseline? What's the variability? My job's done, I can go home. Excellent. Okay, so let's drill down on these and just see exactly a little bit more repetition. So, a definition, mean level of the least oscillatory segments of a trace. Essentially, put a line through it. And at my last session with my local midwives, and bear in mind, I have been in that unit for 14 years, and I've been doing these talks every month for 14 years. It was only last month that an error revealed itself in our guideline. And what in the guideline, the midwives are supposed to look at the fetal heart and document it every 30 minutes and put it on the partogram on a CTG, or every 15 minutes. And what they were doing was, bearing in mind you had a CTG trace, is they were looking at the machine, and at that very millisecond, they were taking the FH, 126, 137. And I used to look at these traces and go, but you've just put an FH of 127, a baseline, but the baseline is 140. And what you've actually recorded was a deceleration. And I don't know if it's the same in your unit, but what we've done now is we've changed it, and every 15 minutes they have to do the baseline, not the FH. Because the tendency is just to look at the machine and write the FH, which ends up looking like absolute nonsense. And you kind of criticize the midwife, said, you must be stupid, you can't even work out a baseline. But of course not, they were just looking at the instantaneous FH. So just a little side issue there that's risen. So the normal range, as we say, and we recognize, is 110 to 160. And I think it's wonderful that despite this range being present for the last, 20 years? Something like that. It used to be 120 to 150. If you look at your machines, they are still highlighted 120 to 150, or 120 to 160. They don't go down to 110. You'd have thought the manufacturers would have worked something out by now. I think it's quite funny that. They haven't quite picked up. But anyway, 110 to 160. That is a normal range. That is a spot range. You have to remember that the FH will change within that range, and that will not necessarily be normal. So just because where you are at that one point does not mean that that heart rate is normal for that baby at that moment in that time. So bear that in mind. But that's the normal range. Between 100 and 110, you could have a bradycardia, you could have an uncomplicated bradycardia, a baby very chilled, very, very chilled out. It may be drugged. It may be all sorts of things. As long as the variability is okay and there is cycling, then whatever the baseline is, you should be relatively reasonably confident. If it is above 160, then if the variability is normal, what's going on? Probably infection. Okay? Probably infection. I always say to people, if you look at a trace and you're going, not sure, don't like it, I say think infection. If you can't work out whether it's hypoxia or not, just think infection. We spend ages worrying and going on and on and on about maternal infection, maternal sepsis, the golden hour, get everything done, and yet we let babies in utero stay there for 4, 5, 6 hours. Where's the logic? And why are we then surprised when the babies come out and collapse and start grunting and need antibiotics for a week? We need to be afraid of fetal infection, fetal infection, let's call it that. And I'm not sure how far this will go. I'd love to come to the back of the hall, but I don't think this reaches. But I can see you. So yes, we need to be afraid of infection. So the high heart rate could be infection. The baseline rate reduces with advancing age. Rise of the pyrexia. It is the first sign, the baseline rate rising is the first sign of hypoxic stress. And lastly, as we said again and again, it will not reduce unless you have made a change. So if you've got a woman who's being induced, who's on Pitocin, and the contraction rate frequency is 4 to 5, maybe 4 to 5 in 10, nothing changes, and the heart rate starts going down, switch everything off. Stop that uterus contracting. That baby is decompensating. So I should be doing this way, shouldn't I? It's decompensating. If the heart rate goes down and you have done nothing to change it, be afraid. Okay, so that's the baseline rate. Here's a little test for you to do at home. No, to do now. Have a look and just have a feel where you think the baseline is. Put it in your head. So, the most horizontal, least oscillatory. This is a very difficult one because it's very oscillatory. Yeah. Okay? Not as hard as the first one I asked you. You got a bit more trace here. Okay? So, this is the kind of this trace where the midwife wrote the FH and said it was 135. And you go, huh? Well, it was at the time that she took it, at 2 minutes. So there are two areas, I think, where you could put the FH. Either about 155, or maybe 160, 65, yeah? Yeah. So what did the computer say? There you go. So unlike intermittent auscultation, which I'm not going to say anything about really, with a CTG, you can give us a short range of where the baseline rises. You don't have to give one number. Okay? As long as your range is no more than 10, because if it's 15, guess what? That's an acceleration. Yeah? So if your range is 10, and so you can say here, it's about 155 to 160, 165, something like that. What is important, just like the documentation, is the communication. What are you trying to say? The biggest disease, now I used to say it was just of midwives, but recently I think it's a disease of doctors as well, is normalization. You're making it normal. Where's the benefit? Okay? Do not make things normal when they are not. Do not try to find normality where there's none to be found. Yes, we need to prove pathology. But if you think about it, what are the consequences of doing nothing when something is becoming abnormal? Things could get a lot worse. The consequences of doing something when nothing's really wrong is a healthy baby. Okay, you may have a cesarean section or whatever, but you'll have a healthy baby. Do not normalize CTGs and say, oh, that's 150. It's fine. Because that's often what happens, especially when it comes across my medical legal desk. So variability. This is the definition. It's the range of the rate above and below the baseline over 1 minute. Now, I call it the bandwidth because in 1 minute, you can have quite a significant change in the heart rate. So you get your calipers and you kind of go up and down around the baseline. The normal range is 5 to 25, very wide. I would discourage any of you of writing, when you're looking at the variability, more than 5, more than 5, more than 5. That is as useful, as we say in England, as a chocolate teapot. Okay? Totally useless. Because if all you write is more than 5, you will miss the gradual reduction as a baby deteriorates. Because if a baby comes in labor, there are no accelerations. But the variability when baby comes in, baby comes in, is, let's say, 17. And when you next review it, it's 15. And then it's 12. And then it's 10. And then it's 7. They are all more than 5. But if you don't write 17, 15, 12, 10, 7, you'll miss it. But if you do write it, you'll suddenly go to yourself, ooh, that baseline, that variability is dropping. I better keep an eye on this baby. I better anticipate where I'm going. And if by the time you got to a variability of 7, the cervix is still only 4 centimeters, you've got a long way to go, you may anticipate how the outcome is going to be. And so it gives you plenty of time to prepare yourself, mother, whatever, and if you are perhaps in a very peripheral area, maybe to transfer the woman, if that's what you think is appropriate. I've said, I'll say again, it is the single most important feature. It is so important to get the variability right. But equally, within that variability, it's not just the number. Is it cycling? So are you having periods of increased variability and reduced variability? Increased variability, reduced variability. Your sleep-wake cycle. Beautiful example of how a baby is functioning is the variability. As the baby becomes tired, what's it going to do more of? It's going to sleep for longer. So you can see this both antenatally. If you've got a woman who's coming in with reduced fetal movements or with growth restriction, and you're watching this baby, the CTG, you can see the sleep cycles getting longer and longer and longer. And you can see that in intrapartum as well. And it gives you the warning, this baby is getting tired. So you're looking for sleep-wake cycle, and even with reduced variability, if it's with drugs or even just by chance, as long as you've got cycling, slightly higher, slightly lower, then you're doing well. Sleep phases may last for up to 40 to 15 minutes, and as I said, beware reduction in labor, don't just write less than 5. It's not very helpful. So examples of variability are here. So absent, silent, also come over here. So very, very little. And this is one of those where you've got shallow decels, so you can see the heart rate drops barely 10 beats a minute. Then you've got reduced, 3 to 5 beats, and that's also got a deceleration or drop of 10 beats. But guess what? That's not a shallow decel. That's just within a variation of the heart rate. You can tell the difference between the two. That one's normal, and that's saltatory. What you can see, the difference between normal and saltatory, I suggest is the angle between the changes in heart rate. So with saltatory, it's a very narrow angle. With normal, it's slightly broader. So you'll see the changes are slightly broader. Saltatory, it's very tight. Saltatory, by definition, is more than 25. If, however, you've still got this angular change, but it's less than 25, then that is sawtooth. The interpretation of this is acute asphyxia. Something acute is going on. If you've got a saltatory trace, you could have maternal-fetal hemorrhage, you could have twin-to-twin transfusion, you could have abruption. The difficulty with saltatory, if it goes on and on, it's a bit like atrial flutter. If you have atrial flutter, your circulation is not effective. If you have a saltatory trace, the fetal circulation is not effective, and you are hypoperfusing the brain. And if it goes on and on and on, you will end up with a damaged baby. So we're talking 60 longer minutes. So you want to be very mindful that if all you have is a trace like that, you need to act swiftly. I believe the new NICE guidelines talk about 20 minutes of saltatory, but we're not going to mention the new NICE guidelines too much today. Accelerations, abrupt. It's a very good question. How would I react to a saltatory pattern? It depends on the information I've got. Now, the example I will show you later on the second section is a woman who comes in with excessive fetal movements. And that's all. She came in with excessive fetal movements. They put the trace on, and there was nothing but saltatory for an hour, 2 hours. And they did the scan, and the scan showed no Lycor. And then the registrar wrote one word which should never be used in isolation in obstetrics: continue. Because I'm in polite company, I won't say what I normally say, but it's usually an expletive, preceded by a no. Anyway, and I would say, and then what? What are you going to do then? You're going to continue. It hasn't changed. But that was in the days of pattern recognition. I didn't understand it. Now, to me, saltatory trace for more than 1 hour, deliver. Because, depending on the gestation, clearly, but equally, just as this registrar did, find out more information. Every piece of fetal monitoring is a piece of a jigsaw. Fetal monitoring interpretation is a big jigsaw, but there's many pieces you want to put in it. Your CTG one is one. Your maternal history is another. Your ultrasound scan is another. Your Dawes-Redman, if you do it, computerized CTG is another. Your fetus scalp stimulation is another. All of these things, the Lycor, is it clear, or is it meconium? Put it all into the mix, and if you end up with a picture which is not good, and the consequences of inaction are quite dire, and the consequences of, let's say, 38-week section is not bad, deliver. Now, what I would say with my patient is, I don't know if it's the same in India, but I'd say, look, I can't guarantee your baby's well-being. I am concerned that this baby is not doing anything that's normal. And I'm concerned it is very unhappy. You're 38 weeks. I think we should deliver you because I can't confirm, even with a scan. Or if I've got a scan that says no Lycor, that's easy. But if I haven't got a chance to do a scan, it's midnight, then I'd say, I think you should be delivered. I wouldn't say it's your choice, but I'd say, that's my opinion. What do you think? But if it's 28 weeks, then just wait. Get more information, absolutely. So, should be visible from the end of the room, accelerations. Usually in response to fetal activity and fetal stimulation. And this is, you can tell this is a British slide because that's an advert from the 1970s for Ready Brek, which is a porridge. And it used to give you a warm glow inside when you had Ready Brek. So that's what accelerations have got to do for you. They've got to give you a warm glow, make you feel comfortable that everything is fine. Clearly, it must be present on an antenatal trace, and as a rule of thumb, 2 in 20. 20 minutes, 2 accelerations, happy days. If you've got 1 acceleration, okay, this baby's not overtly hypoxic, but that is not a healthy, normal CTG. And you need to look further. You don't normally get accelerations in the second stage, and if you do, think maternal. I can't tell you how many traces I've got of maternal traces in the second stage. It is incredible. But you do get some babies will, I call them adrenaline junkies. And every time the uterus contracts, they go, hey! And the heart rate goes up. And it happens in the second stage. And it's great, because my midwives come to me and say, look, Mark, it accelerated. You're wrong. I go, no, the fact that you've come to me showing me the trace means I'm right. Babies don't normally accelerate, but there's always an exception to the rule, and all babies are awkward. And they may incorporate a biphasic acceleration. Has anybody heard of this biphasic or bimodal acceleration? No? It's a term, well, the biphasic acceleration is my term, but bimodal is what some other people call it, and it is a beautiful, beautiful, very discrete tool that you can use to tell you whether the baby is healthy or not. The special place for that is really on the fetal assessment unit or maternity assessment unit when a woman comes in with reduced fetal movements. And you put on the trace, and the trace is bobbing along relatively okay. You have accelerations, but within the accelerations, you have a V. So you have a notch. There's only one thing in the human physiology or fetal physiology that causes a V. Straight down, straight up. Cord. Yeah? So you're getting cord compression during fetal movement. Two reasons that could be happening. One, the cord is around the arm, around the leg, whatever, fine, that's normal. But the other reason is that there may be no lichor or reduced lichor. And when baby moves, it's catching its cord on its shoulder, or its arm, or its bottom, or whatever. And that is one of the very early signs of fetal well, it's not fetal well, it is fetal placental insufficiency, because you've got reduced lichor, you've still got a healthy-ish baby, still accelerating, but it's demonstrating cord compression. And more than once, I've seen women come in to my FAU, and I've gone, hang on a second, let's just do a scan. Done a scan, and there's anhydramnios, or very, very, a single deep pool of 1 centimeter. And they're induced, and they, have a good outcome. But these are the women that you can catch and prevent an unexplained fetal demise. Beautiful use of physiology in action. So that's biphasic acceleration. I'll show you some more about that later. Decelerations.
Can I?
Yes, of course you can.
Yeah, but in labor,
Yeah.
once the
Irrelevant. Yeah.
membranes have gone,
Yeah.
and why would you do an ultrasound scan?
No, you wouldn't. This is antenatal. This is antenatal. In labor, I would go, well, yeah, clever. Membranes are gone. Of course it's going to have biphasic. But at least it's accelerating, so it's healthy. No, you don't worry. This is antenatal intact membranes. So decelerations, yeah, a reduction of 15, lasting at least 15 seconds. As I was talking to you right at the very beginning, the heart is a muscle. It gets tired. And it will eventually say, do you know what? I can't be bothered. You can stimulate me all you like. I am not going to respond. I'm just going to lie here and just beat what I can. But equally, it may be a pure physiological response, a baroreceptor response, head compression or core compression. And in fact, you can often tell the progression from first to second stage just by looking at a CTG. You've got you're bubbling along quite happily, and then suddenly you get these decelerations. So I said to the midwives, well, why don't you just examine her? And they go, well, I examined her an hour before. I said, do it again. I bet you she's fully. They do it, she's fully. But equally, if you think you're getting baroreceptor decelerations and you think it's head compression, and you do a vaginal examination, you find it's -3, think again. That doesn't sound like head compression to me. Okay, so all the pictures, all the pieces of that jigsaw need to fit, and it needs to be the right piece for that place. And if it doesn't fit, think again, something may not be going right. So going further into the decelerations, into a bit more detail. So baroreceptor. I said there were 2 types, and the way that you can, and they're both physiological. So head compression, these are the ones that we used to call, or still do call, early decelerations. I prefer to call them what they are. Core compression, I wouldn't call that. Head compression, baroreceptors. The way you differentiate them from cord is they are synchronous with, in other words, they start and finish with the contraction, and they mirror the contraction. So as the contraction grows, the deceleration deepens, and as the contraction wanes, the deceleration fades away. So synchronous with and mirrors. Not caused by hypoxia, but do not be lulled into a false sense of security. As we saw in one of Raj's CTGs, that those deep decelerations, they are not caused by hypoxia, but they do cause hypoxic brain damage because they cause hypoperfusion of the brain, as we'll see later. So just because you're saying, oh, they're head compression, that's not hypoxia. It's not caused by hypoxia, but it will cause hypoxic insult to the baby's brain because of hypoperfusion. The other type of baroreceptor is cord compression, and these are normally synchronous with, but do not mirror the contraction. So they are contained, usually the start and the beginning are within the start and the beginning of the contraction, but they start and finish inside that. You can, in fact, have late cord compression because the maximal cord compression is after the peak of the contraction. That's why it's so important to call it what it is. It is a baroreceptor. Do not, because if you're going to use earlies and lates, you'll have to call it late because the peak and the trough are different. But if I go back 5-10 years and I talk, or I talk to anybody here who's using NICE, I say late decelerations, you're going to be worried, and understandably so, because that is chemoreceptor. So, but you can get baroreceptor cord compression after the event, and I'll show you some of those, obviously, shortly. So again, cord compression, baroreceptor are not caused by hypoxia, but they can definitely cause damage. Prolonged partial hypoxia, subacute hypoxia, where if you get repeated decelerations where the heart rate is below the baseline, longer than the baseline, then you'll get increasing damage to the watershed areas, as we'll discuss later. And then we have chemoreceptor, or late decelerations, and this, as I said earlier, whether it's chemo or baro, you stimulate the parasympathetic, so you get the parasympathetic causes a drop, and you get the classic late, which is this one, where you get your contraction, your deceleration, your contraction, your deceleration. The distance between the peak of the contraction and the trough of the deceleration is called the lag time. The longer the lag time, the greater the insult. Short lag time, not too bad. Long lag time, a very tired and poorly baby. If you look on this trace, you also have a higher baseline. It's 150, and I would propose to you that the baby's baseline when it first came into labor was probably more like 130, and it has gradually gone up. So although it is within the normal range, it is not normal for that baby. So you can't apply the normal range across all babies. We can also see that the variability is reduced. It's probably about 3 or 4 beats per minute. So you've got chemoreceptor decelerations, you've got a raised baseline, and you've got reduced variability. Is this baby hypoxic? Yeah. Plan of action? Well, we'll talk about that when we talk about chronic hypoxia. But essentially, you can use your intrauterine resuscitation measures, which we'll talk about, or deliver. Simple as that. You've got 30 minutes to make your mind up, and then another 30 to get on with it. The alternative is this one, where you've got your synchronous deceleration and then your slow recovery. Okay? So that is often a late labor demonstration because you've got head compression and slow recovery. Okay. We're into our first hour. That went quickly, didn't it? How often were you Zumbering?
It's time for the first one. Time for the... You need a Zumba?
Well, I'll be monitoring it now. We'll see. Now's a very good time. Now's a very good time. Come on. Because we're going to talk about core compression, and I need people to be switched on for that.
Yes.
So, ladies and gents, by popular request, was Zumbering. I don't know. Should be interesting. The idea being that I don't want you sitting there for 4 hours getting tired and bored, and I want to see how far this mic goes. Because, oh, hello. Now, you're lucky, actually, because I'm an old man, and I'm long-sighted. So I could see you you're now a blur for me. It's great. So I don't know what's going on here, but apparently Raji has got something organized. So you cannot sit for this next bit unless you have difficulty standing. Okay? So I just want you to just stand up. And the idea being, no, come on, stand up. I'm serious. I'm standing. I shouldn't be the only one standing. The idea being is that you just circulate, you activate, you get the blood going again. And I've got no idea, so I don't care what you do, but I want you to do something that activates, and I don't know what Raj is going to do now, but this could go absolutely horribly wrong. But you've all stood up, which is great. Am I doing the Zumba as well? We have a plan. I've been hijacked. I have no... Excellent, right. So hopefully that's got the blood going from where it shouldn't be, in the bottom of your shoes, to your brain. Because after all we are, as I said, is a brain on sticks. Now, I don't think my brain was working, otherwise I'd never agree to that. But there. Good, okay, so. Feeling revitalized? Revitalized, excellent. You can blame Tony Robbins. I don't know if any of you have heard of Tony Robbins. He's a professional speaker who, I've forgotten the word now, but I once went to see him speak for 4 or 5 hours in a go, and he had us completely riveted. Now, I'm not comparing myself to that at all, but I thought I'd take a tiny piece of information, which was get them to get up. You can keep talking, but get them to get up, do something, and so on. Right, so we've had baroreceptor decelerations, we've had chemoreceptor decelerations, and now we have variable decelerations, or which are, as NICE 2017 defined, decelerations that are neither early nor late, that may be core compression, but maybe not. Not very helpful, is it? And I think what's actually, if you look at NICE 2022, they have moved away from that completely, and they now say that variable decelerations are chord. So why can't they just say chord compression? Anyway, so now variable decelerations are by their nature, if we're going to talk about chord, personally I think there are 2 types of variable decelerations. There are the chord compression, which is what we're going to talk about now, and there are labor variables. And those are decelerations that you look at and you think, oh, they're not early, some are early, some are late, they're a bit all over the shop. Do they matter? 2 questions. That's not one of them. 2 questions. What's the baseline? What's the variability? If the baseline's okay and appropriate for that gestation and that stage of labor, and the variability is reasonable with or without cycling, preferably with cycling, then who cares? That baby could be playing with its big toe, it could be playing with whatever it likes. I don't mind, as long as the variability is okay and the baseline is maintained, and we're having good periods at the baseline, as well as that the decelerations don't last more than 60 seconds. That there is no reduced variability with the deceleration. Now, I used to hear that for many, many years. What is this rubbish about variability in a deceleration? It's decelerating. Why should I be interested in the variability? But that was in the days before physiology really kicked in, and now it makes so much sense. Remember what I said? Sympathetic, pushing up. Parasympathetic, pushing down. The deceleration is caused by parasympathetic strength dragging the heart rate down. Do you really think that the sympathetic is just going to go, hey, that's cool, dude, you do what you like. I'll just let you do your thing? No. The sympathetic goes, no way, Jose, am I staying down here. I'm going to get back up to where I want to be. But the parasympathetic at that moment is so strong that it keeps it down, but you've got variability at the base of that deceleration until it goes back up to the baseline. So that is a healthy baby trying to get its heart rate back up, but the environment, the hostile environment, the parasympathetic is dragging it down. So yes, if you have a prolonged deceleration, You want to look for and confirm that there is variability in a deceleration. And if there is, that's a healthy baby. You remember I talked about three types of babies. Healthy baby, healthy environment. Who cares? Healthy baby, hostile environment, or unhealthy baby, hostile environment. So a healthy baby, hostile environment, once you've got that picture, what do you need to do? Change the environment. Get that environment, improve it. So if she's contracting 6 or 7 in 10, guess what? It's not difficult. Get those contractions down. If it's core compression or whatever, change position. If mum is ketotic, dehydrated, pyrexic, give her some fluids. Antenatally, only intrapartum. So, reduced variability is a bad thing. If it doesn't return to baseline, well, that's obvious. Biphasic, we'll talk about that. And no shouldering, clearly that's the beginning of a bad thing. So, remember at the beginning of this talk, I talked to you about all a baby wants to do is keep its blood pressure stable. And in this equivalence, I simplify things. I put blood pressure equals heart rate and cardiac output or stroke volume. And so, with that equivalence, one stays stable, one goes up, one comes down. If you know which one's going to be stable and you know which one's gone up, then the other one, guess what? It's not difficult. It's got to go down. So I want you to keep that in mind, and we're going to talk about this pattern. Okay, so you've got your sharp V. There's only one thing in physiology that can cause a V. That's cord. And a sharp V. Obviously, you can get a mirrored. So a sharp V is cord, and then you've got your shoulders on either side, roughly of equal height.
Is it the same as M pattern?
No, M pattern is biphasic acceleration. Generally, so this is not an M. I've never heard it called an M, put it that way. But it's shouldering, sorry, it's core compression with shouldering. So it's a non-hypoxic core compression. So at the top left, you have your equivalents. Blood pressure, heart rate, cardiac output. On the right-hand side, you have your cord. There it is. You've got your cord, you've got your two arteries. Thick-walled, small, don't compress easily, spring back very quickly. Blood going from baby to mum. Underneath, you've got the vein, thin-walled, easily compressed, opens up very slowly because behind it is the low pressure of the placenta. As you get core compression, the first thing that happens is the vein gets compressed. When that happens, what you have, no blood coming from mum, but the artery is still open, and so it is pulsing. That is hemorrhage. So if you look at your equivalents on the top left, you've got hemorrhage, so your cardiac output is going down. You want to keep your blood pressure stable, so your heart rate has to go up. And it's what we call a reactive tachycardia. It is not essential for fetal life. If a baby's tired, can't be bothered, maybe it's a teenager, it's not going to bother. It's just going to say, do you know what, I'm not going to bother. So remember that. But if a baby's healthy, it will respond to the relative blood loss, and I'll give you a reactive tachycardia. As you go from partial compression down to full compression, your artery and your vein are both compressed now. So now, there's no blood going out, there's no blood coming in. So the cardiac output is now stable. However, you've now cut off the supply, the connection to the placenta. And the placenta, as I've been saying, is what? Low pressure. So your baby's resistance, peripheral resistance, has gone rocketing up. Cardiac output is not going up or down, so it's stable. The resistance has gone up, and therefore, the heart rate plummets. Okay? It's a baroreceptor response, pure physiology. It goes straight down. It has to do that because it thinks that in the brain it's going to blow a vessel. So it has to protect the brain and drops the heart rate. We then get partial easing of the compression into what I call my pufferfish. So partial easing. The arteries, being very elastic, spring open. But the vein, slow, low pressure, doesn't open. And so initially, you have the artery pumping. No, sorry, let me correct that. The first thing you have when the artery opens is not the artery pumping, that's the next step, is equilibrating of the pressure. Because you've got such high pressure difference, before you get any flow, the pressure equalizes. So the huge pressure resistance, peripheral resistance, comes crashing down. There is no flow, and therefore the heart rate comes back up. Just go through that again, because I've got a slight mistake there. So the first thing that happens as a slight relaxation is the arteries spring open and reconnect to the placenta, the low pressure system. So the first thing that happens, you've got very low pressure, very high pressure, there's equilibrating of blood pressure, there's no flow, blood pressure comes down, therefore the heart rate comes back up. But this vein is very slow to open because it's very low pressure. So now you've got hemorrhage again, slight reactive tachycardia, and so you get the second, gone too far, you've got the second little shoulder. Again, this is not essential for life, but then we have complete relaxation, opening of the vein as well. Everything goes back to normal, and therefore the heart rate comes back to normal. Okay? Because of the unique relationship of the differential compression of the arteries and the veins, because of the low pressure system in the placenta, that is why you get the unique feature in a healthy, non-hypoxic core compression. Nothing else can cause it. If you see it, call it by its name, non-hypoxic core compression. One thing I just wanted to say, because you'll hear me again and again say about physiology, is, and I think Roger mentioned it, is even if you're going to use NICE or FIGO, if you understand what's happening to the baby, you can still use whatever guideline you want and incorporate your physiological understanding in your plan. So you can use whatever guideline and whatever parameters you like, and this is an extra level of knowledge which you're applying. You then have to adapt how you communicate. Hopefully, eventually, everybody will be physiological and it'll be a lot easier. So, variable decelerations have a variation in their appearance, depending on how healthy or not baby is. So, first thing we have is our straightforward non-hypoxic core compression. You've got your V, and you've got your two shoulders of roughly equal amplitude, front and back. The first thing that happens as baby is becoming tired is you get an overshoot of the second shoulder. Now, it took me a while to try and work out why or how to explain it, but then I came to realize, in fact, if you remember, we said right at the very beginning, I think it's slide 2 or 3, that the placenta is the baby's lungs. So if you are interfering with that connection, basically the baby is holding its breath. So for every deceleration, it's holding its breath. Now just like there, what I did is I held my breath and I just kept talking. So that was my normal shouldering. If I ran, here's a good example, just after doing Zumba, if I held my breath and then tried to start talking, what was the first thing I would do is hyperventilate. Because doing Zumba used up a lot of my oxygen, or in fetal terms, made me produce a lot of carbon dioxide, which I needed to blow off. So in the slight overshoot, what you're seeing there is a baby that has already got a slight extra carbon dioxide on board. It's been asked to hold its breath and then breathe again, and then it's had a slight hyperventilation or tachycardia, which is why the first thing is a slight overshoot of the second shouldering. If I go back to, of course. The overshoot is when it's bigger than the first one. Yes, as in that one, as in this one as well. So inadvertently, I actually put this trace just as an example of different types of variable decelerations. And it was only when I started explaining why you get an overshoot, and I looked at this and I thought, do you know what you've got here on the left-hand side is you've got a straightforward, equal shoulders, happy, non-hypoxic core compression. Now, you can see here the baseline's 100, the variability is fine. But clearly, if you look, you've got two contractions very close together, followed by an overshoot on the second core compression. And as we know, there is no placental circulation when the uterus contracts. And putting those two right close together, maybe, just maybe, put that little baby over the edge, made it a bit tired, and so when it compressed its cord, it then had to have a little extra breathing session. I like that story. You can take it or leave it. But the principle here, you see on the right slide, you've got a small shoulder on the left, and you've got a big shoulder on the right. Okay? Then, if you push baby even further, it's going to start complaining. This baby is not going to be happy, and it's going to have a tantrum, and it's not going to do those little overshoots because it can't be bothered. And so you're going to lose the shouldering. So you'll still have the V. The V is mandatory because that is protecting the baby's brain from what it thinks is going to burst the vessel. So it does the V, it protects its brain, but it cannot be bothered with these extra little fancy tachycardias, and so it doesn't do them. You can also hopefully see the baseline here is 160. And it looks like the variability is a bit reduced. So you've got several things already telling you this baby is not very happy. And on top of that, you've now got a core compression with no shouldering. And then on the right-hand side, you've got the very ominous, what I call Uing. So you've gone from a V to a U. A bit like the very first trace I showed you of those twins. That was a Uing, very wide deceleration with no variability. And that is very ominous. A biphasic deceleration is a very interesting concept. So here you have a biphasic, where you've got one long hit, and if you think about when you've got a baroreceptor followed by a chemoreceptor, you just get a deceleration with a slow recovery. Yeah? Do you remember that? Deceleration, slow recovery. Here, yeah, we don't do that. Because it doesn't tell you what it says. Atypical for whom? You're atypical, my atypical, you're atypical, very different. Atypical has gone. Typical has gone. Sorry? You could say, yes, this is if you're going to use nice termination, this is a variable with concerning characteristics, the biphasic. Yeah?
But basically they are the same, right? They just change the nomenclature, right?
Yeah,
Yes. The typical variables used to be non-hypoxic core compression. Number one, top left. Everything else is atypical. So interestingly, if you just call them all atypical, which one are you talking about? Yeah? So it's very important to describe it very descriptively, to use two terms of the same word. Say what you see.
Say that anything which is not a typical variable deceleration, all the atypical ones are of concern. Would I be right?
They are of interest. So then I ask you two questions. Same two I've been asking all afternoon. What's the baseline? What's the variability? Now, if you go to the second one on the left, you would tell me the baseline is 160, the variability is 2, I'd be going, I'm very worried. The one on the bottom right, I don't know what the baseline is, but the variability is 0. I'm very worried. Top right, well, the variability is probably okay, and the baseline is probably okay. I'm interested. The bottom one is interesting. It's very interesting because you're getting your baroreceptor hit, slight recovery, but instead of the chemoreceptor doing a continued recovery but slow, it's giving you a second hit and recovery. So you're getting a double whammy with the same insult. What's that?
Deceleration by 15 beats per minute for 15 seconds.
For at least 15 seconds. So that's a drop of from 190 down to 120.
The third and the fourth one.
They are still, the third one is 30 seconds.
The
It-
dip is 30 seconds, but the base,
No, it's from start to finish.
but that is 10 seconds, I believe.
The base is from 160 to 120.
That is beats per minute.
Yes.
That is drop. But the base for seconds duration.
No, it's not the base, it's from start to finish, not the base. It's got to be start to finish, it's got to be 15 seconds. So from start down to the base to recovery is 15 seconds.
Correct. So in the third, is it 15 seconds?
Yeah, it's 30. Because each square is a minute. Each big square, so that's 30 seconds. Yeah, it is. But thank you for pointing that out. But yes, it is definitely 15 seconds. More. So if we look at the biphasic, what's the baseline? Roughly. Yeah, the biphasic. Baseline.
About 190.
Yeah, it's about 190. And it lasts for 3 to 4 minutes, yeah? So it's very concerning. However, if I deliver this baby now, would it be good condition or bad condition? No. It wouldn't be bad. But you would think so. Why do I say to you it wouldn't be bad? Look at the bottom. There's variability in the baseline. So this is an awful, awful trace that needs Cat1, get on with it, but it doesn't need a GA, it doesn't need a stat, it just needs, we need to get on and deliver this baby. Because it will come out crying because the variability is normal in the baseline, at the bottom. Okay?
But we don't know how frequent that is coming.
Oh, no, sure. I'm not saying giving you a global picture, but I'm saying as a snapshot, this baby at this moment in time is a healthy-ish baby in a very hostile environment. So yes, get the baby out and get the baby out quickly, but I can say to my anaesthetist, yeah, you've got time, and I can say to my staff, chill, it'll be fine. But let's get on with it. Just a little side story, because somebody was talking about a Cat1 or saying how long you have to deliver a baby. And you've got 30 minutes to deliver a baby. I did a study once, a study of N of 1 in my unit. And I called a Cat1, which everybody says, yeah, okay, it's 30 minutes. And then I looked at the clock, and I want the baby out by 7:05, which, by the way, is in 30 minutes. They moved so much faster because they had a deadline. It's very just something to take home. Is if you want somebody to be delivered very quickly and efficiently, give the people a ticking clock, not just, let's get on with it.
But the family shouldn't listen. Once I said that, when the husband is staying beside, they listen to what you say. So if you fail to keep that deadline, you are in deep trouble.
Correct, but then you're in big trouble because you haven't kept your 30 minutes anyway. So it focuses the mind. And in fact, I'm tempted to get a big clock for my labor ward. There, I move on. Okay, so that's what was that? That was decelerations. Any other questions about deceleration? So we talked about baroreceptor, which are not hypoxic, caused by two things, head and cord. We talked about chemoreceptor, which are not necessarily very good, decelerations, and we talked about core compression, which are also baroreceptor, which we, as we know, used to be called variable, but we don't call them variable anymore. Any other questions at all? Yeah? Nice and loud. Yeah. The biphasic. No, what I said was, with the biphasic, Late cord compression. Yes? Yes. We'll come back to that when we talk about prolonged partial hypoxia. So I do cover that. The question was, how long have we got to deliver the baby when you've got cord compression? I said we'll come back to that when we do prolonged partial hypoxia. Anything else? No? Okay. So, fetal acid base status. This is so that we can understand why we say various terms as we go through the baby's physiology and see how baby is. So there are 3 conditions, if you like, 3 gradual deteriorations. So you go from a normal, healthy, happy baby, and the first thing that a baby will experience when the placenta is not working very well is hypoxemia. Okay, this is a condition whereby I call it a grotty placenta. So your preeclamptic mother with IUGR, baby's just not getting enough of what it wants. Equally, this could be your patient coming in at 41 weeks for induction where the placenta really has just run out of steam. Or it could be your diabetic mother with a baby that's outgrown its placenta and it's just not keeping up with the baby's needs. So the baby realizes that things aren't quite so good and it's not getting quite enough goodies, and it will redistribute, it will conserve energy, and it will make sure that its adrenals, its heart, and its brain are preserved and get enough exercise, get enough energy. So it will grow less and it will move less. The next step, if you push that baby into labor, is hypoxia, a condition we are all very familiar with, where you get peripheral redistribution, you get anaerobic metabolism in the peripheries, but the heart, the brain, and the adrenals are spared. And then you get asphyxia, where all hell breaks loose, and you get anaerobic metabolism in the essential organs as well. If we look at it graphically, hypoxemia, days, weeks, we know that. This is growth restriction. This is, you're watching this baby, and it's growing slower down, it's not meeting its potential. Babies are parasites. Those of you who've had babies, you know those babies are parasites, and they will take everything out of you, and they will leach you for all you've got. They are very effective uptake of oxygen. So we don't really worry about oxygen, but it's not going to move as much. It's going to decrease its growth rate, but it's maintaining its energy balance until you push it over. You may find this is one of those with hypoxemia where you get longer sleep cycles and shorter wake cycles. If you go into hypoxia, first sign of hypoxic stress, surge in stress hormones. Your adrenaline, your cortisol, the baseline rate goes up. You get redistribution of blood flow away from the peripheries, and you get peripheral anaerobic metabolism. But for the moment, baby's energy is maintained. It is okay. Until, guess what? More Pitocin, you push it over the edge, and it goes into asphyxia. You get the alarm reaction, the saltatory trace. Could be one of those examples. You might get a bradycardia. All hell breaks loose, the heart fails to function, and you can get that gradual decompensated, that horrible trace that you watch when nothing you can do can stop it. Days, weeks, hours, minutes. If we're talking about hypoxia, there are 2 types of hypoxia that we are familiar with and which we need to be talking about. One is subacute or prolonged partial hypoxia, and the other one is acute total hypoxia. Now, acute total hypoxia, everybody's very familiar with that. Heart rate's bombing along, suddenly it crashes down, and it stays down, your bradycardia. So that's your cord prolapse, your abruption, your uterine rupture, and so on. Baby can survive 10 minutes before he gets acute permanent brain damage, and there is no gas exchange at all. The pH drops by 0.01 per minute, the base deficit goes up by 1 millimole per minute, and as I said, they're increasing brain damage between 15 and 25 minutes, and by 25 minutes, most babies are unfortunately dead. You can see there, it affects the basal ganglia, the bits in the middle. The reason it affects the basal ganglia is that those are the bits that metabolize the fastest and require the most supply of oxygen, and as soon as you interrupt the oxygen supply, then you get damage to the basal ganglia. So a short, sharp shock, let's say 11, 12 minutes, you may have a bit of spasticity or a little bit of rigidity, but intact intellect. The longer you go on, the greater the damage. Prolonged partial hypoxia. This is when the heart rate is below the baseline for longer than at the baseline. Another version of that is your saltatory trace. So if you've got a saltatory trace, you're not using your heart is not pumping properly, and you're not supplying the areas of the brain that you need. And as we know, the blood supply to the brain is from 3 arteries: the anterior, the middle, and the posterior cerebral artery, and they anastomose. The reason they anastomose is if you block one, the other one supplies it. But with this, we don't have a blockage. What we have is complete hypoperfusion. So the blood pressure to the brain drops, and you don't get the blood supply to what's called the watershed area. And if you don't supply the watershed area, then that area of the brain dies. And you can see those in dark purple, section A and B. It takes 60 minutes to cause damage to this area of the brain, unless there is infection with fetal response and cytokines. And the theory goes that if you have infection present, you can halve the time taken for any similar injury. So please think twice when you've got infection as to whether you want to add insult to injury. It's called the sprinkler effect because if you've got a sprinkler with a circular radius watering and you drop the water pressure, the radius will shrink and the area outside won't get watered, and so the grass dies. An example of this is this kind of trace. So you see this trace. What is causing those decelerations? Very straightforward. Core compression, okay? So you get core compression. Clearly, we're contracting too often. And you can see that they've tried to change things. Turn onto left side. The registrar is present to review. The baby is doing what it can. You see the baby's baseline rate at the beginning is about 150, 145, and at the end it's 150. The variability is not brilliant, but it's not too bad at the top. And you've got periods of recovery. So at the moment, baby is just about okay. But if you keep pushing, you can see here, the gaps in the recovery are getting longer and longer. So the baby's spending even less time at the baseline rate. Interestingly, it is still responding, hold that thought, it's still responding at the deceleration. So this baby is doing what it can, and it's put its heart rate up to 160. So it's responding physiologically. It's seriously stressed, and it's just saying to you, please, stop this nonsense, stop the contractions, I need to recover. But I'm not getting any time to recover. And it goes on, and you can see longer and longer periods in between, and they just continue. They make the mistake of doing a fetal blood sample. This baby is not hypoxic. It's getting enough oxygen. The oxygen is just not getting to the brain because of the cord compression. It's getting to the periphery, so the baby's not hypoxic, but the brain is being hypoperfused, and so they were falsely reassured. You can see the heart rate now is 180, and this baby eventually delivers 2 hours later and is quadriplegic and severely brain damaged. Totally and utterly preventable. So that is prolonged partial hypoxia. 60 minutes you're allowed. That is an example with core compression, but you can get an equally severe example with head compression, because the heart rate will go down with the head on the perineum. Do not leave it on the perineum. Deliver it. Episiotomy if necessary, instrumental if necessary. No more than 60 minutes or 30 minutes if you've got infection. Prolonged partial hypoxia. Okay, so if we look at, when we're thinking about cord gases, what gas exchange, I'm sure you're very familiar with this. So in labor, we have a decrease in placenta blood flow because of the contractions. That causes a reduction in gas exchange. Now we're going to go down the left-hand side first. First thing that does is a carbon dioxide accumulation. Remember, babies are parasites. Oxygen transfer is active because of the differential oxygen dissociation curves of the fetal hemoglobin and the maternal hemoglobin. So oxygen comes over actively. Carbon dioxide is a passive transfer. If you interfere with that transfer, the carbon dioxide will build up. That creates respiratory acidemia, which, ladies and gentlemen, creates a decrease in pH, which is labor. That's normal. If, however, you push it faster and further, and not only do you get a carbon dioxide accumulation, but you will eventually get a reduction in oxygen. That reduction will cause hypoxia, that will cause anaerobic metabolism, and that will cause metabolic acidosis, a much bigger drop in pH, a much bigger base deficit. If we look at it pictorially, I do like looking at things pictorially because I'm left-handed, and left-handed people apparently like pictorial things. So here we have the same thing. Going from left to right, we have the hemoglobin, the glucose, with the oxygen combining in aerobic metabolism. The energy that's produced is there. The byproduct is one carbon dioxide molecule, one water molecule. They combine to form one bicarbonate, one hydrogen ion. The hydrogen ion creates a drop in pH, the bicarbonate is around, and the base deficit, which you can also call base excess, but I think base excess is confusing. Base deficit is the same number, just no negative. The base deficit is the amount of base you have to add to bring the pH back up to neutral. That's the way I describe it. Makes it quite simple. You've got some bicarbonate hanging around, some of it's gone into the tissue, you've got a drop in pH, you have a small drop in pH, small base deficit. If, however, you push a bit harder and you lose your oxygen, you still have to form energy. So now, the baby's hemoglobin takes glucose and glycogen from the liver, combines in anaerobic metabolism to create the energy, and the byproduct of that is not carbon dioxide, not water, but pure lactic acid. So you've got lots of hydrogen ions, no base, big drop in pH, big base deficit. The other thing that you don't have is carbon dioxide. So your PCO2, if you have a pure metabolic acidosis, like we saw with Raji's last CTG, you remember that was the lady who came in with a flat trace and then that became undulating. Although we didn't have the PCO2, I bet you the PCO2 was normal because it was pure metabolic acidosis. There was no respiratory acidosis. So they're the two. Respiratory acidemia, you get a high PCO2, small pH drop, small base deficit. With metabolic acidosis, you get no significant change in the PCO2, big pH drop, and a big base deficit. Now, Mother Nature is cruel, and she's never that simple. So it's usually a combination of the two, and you have to work your way around it. So if we look at the pH gases, the arterial is always lower than the venous. The upper limit of the PCO2, I think they're coming. The upper limit of the PCO2 and the upper limit of the base deficit is 10. Okay? So as I said, base deficit and base excess is the same thing. I prefer base deficit because if I say the base deficit's gone up, then that's worse. If you've got a base excess that's negative and you say it's gone up, well, has it gotten closer to zero or has it got worse? So it's a bit confusing. So base deficit, 10 and 10 for the PCO2, and you see there the pHs. If you have an acute hypoxic event, so you're doing an instrumental, you've got a shoulder dystocia, whatever it takes, you'll have a large gap between the venous and the arterial. The reason is that the venous is a snapshot of what mum is, and the arterial is what baby's being produced. Now, why you say, well, hang on, if you've got some occlusion or something like that, why do you get an accumulation in the artery but not the vein? Well, if you remember back to core compression, the vein gets compressed very quickly. So the blood coming from mum is stopped, and that's a snapshot. But the baby's artery is still pumping, okay? So you'll still get a difference. If you get a very long acute, you'll have a much higher PCO2 and a much higher base deficit. But the factor of an acute is a big split, significant difference between the pHs, the base deficit, and the PCO2, between the artery and the vein. If it's more chronic, you can see there that the pH of the artery and the vein have got closer together. The PCO2, as you can see, is closer together, and the base deficit is also closer together. So acute hit, wide gap, chronic, close, acute on chronic, much worse. It's said that you have to have a difference of 0.05 in pHs to reliably have an artery in a vein. That's a good rule. I have done core pHs when I didn't believe the midwife had got two different chords, but she had, and they were very, very close together. So it can be close, but as a rule, at least 0.05 difference. There's been a lot of talk about fetal scalp stimulation. I'm a huge fan. I just put that from the nice quote from 2022. I think that it is, if you do fetal scalp stimulation and you get a positive response, there's plenty of published evidence that says the chance of the baby being hypoxic is very low. Now, I think the question that Raji asked me is, how long have you got once you've done fetal scalp stimulation? Who knows? But I would do it on every single VE. Do it antenatally. If you do a vaginal examination antenatally, if you do it intrapartum. You know, it was interesting, I think on one of Raji's traces, I noticed that there was an ARM and there was no change in the heart rate at all. That should give you concern. Why did that baby, an ARM, for goodness sake, that's, pretty serious stimulation. The baby should respond to that. And if it doesn't, ask yourself why. And fetal...
It just didn't say an acceleration with the fetal scalp stimulation.
Yeah, that's nice. I don't believe in it.
Yeah, it did say improvement.
It's rubbish. Fetal scalp stimulation. In 2017, this is a new slide from last night. I changed it last night just for you. Because I used to have the 2017 one on, which has said if you do fetal scalp stimulation and the trace is no longer pathological, then you can be reassured. Fetal scalp stimulation is not going to improve the CTG. So likewise here, it's not going to improve the CTG. So nice. I put this quote up just to ignore it. If you get a response, that's good, but you can't ignore the rest of the trace. It means that at this moment in time, baby is responding. Now, if I take you back to some of the horrible traces which had variability in the decelerations, they might respond, but the trace overall is not good. Excellent. That's the end of that section. I'm not going to ask you to Zumba again. Huh? One more second. We'll do it after this then. Okay. So we've been here 2 hours. Okay, I'm going to ask you just to stand. I'm not going to ask you to Zumba, I promise. Not this time. We will, but please, come on, stand, shake your legs, get energized. I've done 2,000 steps since I started 2 hours ago. So there you go. Just shake, get yourself circulating. That's it. Because we're all halfway. It's great, isn't it? You'd be glad to know I cannot keep this. Do you know I have to do this all for a whole day every month? I must be mad. Anyway, good, excellent, right, lovely. Let's crack on. So this is what you've really come for, isn't it? These last 2 hours have been a complete waste of time. This is what you wanted. This is why you brought me over. So here we go, physiology. Let's talk about it. So, physiological interpretation. Why do I think it's brilliant? I really think it's brilliant, and I hope that by the time I finished with you today, and please, I'm here all weekend, so please come find me. I'm very approachable. If you've got anything you want to talk about, I'll be very happy to discuss it. I want you to convert you. The pure physiology is the way to go because it's so useful, helpful. Why? If you're pattern recognizing, you just pattern recognize, you put your brain in neutral and you just, whatever. With physiology, you have to understand what the baby's doing. You have to understand what is going on to that baby. What is the environment? How healthy is that baby? We talked about fetal reserves. How much reserve has this baby got? Can it cope? All of these things come into your calculations to what you're going to do. You have to define the environment. You do not have to wait. I mean, the very first slide I showed you, 2 minutes, that's it, I don't need anything else. My physiological understanding said, that is hypoxic core compression, twin pregnancy, 33 weeks, section. Get on with it. I do not need any more than 2 minutes. Now, if people were trying to pattern recognize, as they did, they went, I don't know what, I can't understand. I've got my template of earlies, my lates, my variables, and it doesn't fit, therefore, continue. You don't do that. You can just get on with it. And you individualize the care. This woman, this baby, this labor, this time now. Not tomorrow, not last week, not next week. Where am I now? How am I going to act now? And it may well be that next week I will have a different plan. I always tell my ladies, because I deal with all the ladies with mental health issues, and they like a plan. But I always say to them, we've got a plan. They go, oh, good. They go, all plans can change. But they go, that's fine. We have a plan, and I like a plan. And it divides the babies, as I said, healthy baby, healthy environment, healthy baby, hostile environment, and then unhealthy baby and hostile environment. And that's really what you're trying to work out. Where am I? And how is this baby fit for labor? Is this baby fit to continue pregnancy? So what do? We observe. And the observe is, as Georgie said, is your Dr. Steve Bravado that we're familiar with. The relevant clinical features, review the trace, and almost the first thing you need to say is, show me the previous one. I want to compare. And they may say, the previous one was 10 weeks ago. That's fine, what was the baseline? I want to make sure the baseline's gone down. I want to make sure that this is the right place. Now, it may be that you don't have a previous CTG, and then you've just got to work out, well, is this the right baseline for this pregnancy at this stage? You classify, you document the 4 features, make sense of them. Baseline, variability, accels, decels, whatever's going on. Cycling, not cycling. And you allocate the trace to one of the 9 categories. Now you go, 9 categories. How am I going to remember that? I can barely remember, what was it? Variables? Typicals? I can't remember. Anyway, it's going to be very simple, I promise you. If it's not, I'll give you your money back. She'll give you your money back. Anyway, one of the 9 categories. It is simple. And then you predict. Standard CTG interpretation does not predict. It just says, I'm responding to what's happened, not predicting. The whole point of it is you're going to say, nullip, 2 centimeters, 8 hours to go. It's not going to work. I'm not going to get there. Now, that doesn't mean that you don't try, but you can start saying the seed, okay, we'll give it a go. We'll keep it safe. If the trace deteriorates, we'll bail out. But I'm just warning you that baby might not be very happy. It might not make it. And I mean, I don't know how your women respond to cesarean sections, but in the UK, a lot of them are traumatized because they wanted their very comfortable birth, quiet lights, dim lights, nice music, and it was all going to be what my midwife says. It's a Disney delivery. Very few deliveries are Disney deliveries. And they get really upset and very traumatized by going from Disney to section. It's gone from Disney to Disney Plus. It's not a good comparison. So it gives them time. It gives you time. You can predict, and you're not suddenly going, oh my gosh, I must do this now. You can go, yeah, I knew we were going to get to this place. Right, let's put it, we're ready. We're cannulated. We've got consent signed if we want it. There's no delay then. And then you act, and you individualize in anticipation, not in response or reaction. That's the beauty of it. So, I'm not going to go through all the features again, don't worry, we're not starting at the very beginning. 4 features we talked about, yeah? Baseline, variability, and cycling. It needs to be ingrained, automatic, reflex. The variability is, cycling is. Present, not present. It's the same sentence. Cycling with, variability with cycling. Accelerations, yes and no. As we know, accelerations in labor, not necessary, but nice. Decelerations, are they chemo or baro? And then you can do your Dr. C, M, if you use M, Bravado. So I'm going to go M could be either membranes or meconium. if you want. That's why it's in brackets. Most people go, there's enough letters in Dr. Stupevado, I'm not adding another one. Having said that, I'm a great fan of meconium. Oh, not meconium, Lycor. And just like I do vaginal scalp stimulation at every V, push the head up a bit, get some Lycor down, every time. You don't get a bonus point for a vaginal birth and thick meconium at delivery. What you get is an anticipated meconium at delivery because you knew it was there. So I'm going to go through the categories, just list them, and then we're going to go through them in detail. So reassuring, normal, straightforward. The first four are sequential. One follows the other, follows the other, follows the other. So we're going to go normal. Hypoxemia. Now, hypoxemia is only antenatal. And some places who use physiology don't talk about it because they just go straight to hypoxia. But hypoxemia, if you are alert to it, is such a useful tool. And as I'll show you with the example I've got here, it avoids the sudden disaster because you're going, aha, your placenta is not working very well. We need to keep a very close eye on you. So if you're going to do your Foleys, or as we use in the UK, your Dilapan, or your Propes, or because you use Prostin, don't you, not Propes? Yeah. Whatever. You normally have an interval for fetal monitoring, where you might shorten it, or you might say, as soon as you start contracting, let me know, because that might push the baby over the edge, and I want to catch the baby before there's compromise. So it's very useful to spot it, and I'll show you exactly why. Then you have gradually evolving hypoxia. Again, this could be antenatal. If you're watching it over days, that would be most unusual. More likely to be intrapartum. And once you've got gradually evolving, the next one is chronic or established hypoxia. So those four sequential stages follow one another. Normal can be intrapartum antenatal. Hypoxemia can only be antenatal. Gradually evolving is usually intrapartum, but could be antenatal. And established, if you're unfortunate enough, could be antenatal, like we saw with Raji's last trace, or can be intrapartum. Now we have the two different hypoxias, acute, subacute, or prolonged partial. Then we have infection, and then we have anemia. When he gets to it. Come on. Good. Whoop. Whoop. It's getting tired, just like the rest of us. Anemia. So I told you, it's not that difficult, is it? Chronic and acute. Now, I accept there's no such thing as acute anemia, but it falls into a nice category. And then we have uninterpretable, which you can only use once a month. Okay, you can never use it more than once because you can't allocate all your traces to uninterpretable and move on. But we'll talk about that. Okay, so there's 9 categories. We'll go through them, then we'll Zumba. Because I know I've been told that we've got one more, so we'll do it. So, let's go through. Number 1, reassuring trace. All the features are as they should, as you would expect, for that gestation, whatever it might be. And a normal, non-hypoxic, non-infective, whatever, healthy baby. The baseline hasn't changed up or down without an explanation. If it has changed up, 3 reasons why it could have gone up. Maternal stress, fetal stress, infection. So it may have gone up because mum's stressed. And then if you can explain that, then it's normal. It may have gone down. Of course, you'd expect it to go down with gestation. Cycling is present with good periods of awake. Nice periods, 10, 15, 20 minutes. You want to see a nice cycling of the baby. Antenatal must have accelerations, 2 and 20. And beware, as we talked about, biphasic accelerations. And I will show you some. So here is a normal trace. Baseline is about 125, 130, probably 125. Variability looks about 10 to 20. Accelerations are present. There are no real decelerations. I would ignore that thing at the end. But these are biphasic accelerations. Yeah? Look at the one just in the middle to the left of the vertical axis. You've got You called it an M. Yeah? You can see there's a sharp V within that acceleration. If you go towards the right-hand side, you can see there are notches. So this is a very healthy baby, but I would be very interested to know what's the Lycle volume, and is it normal? But it's a normal trace. A biphasic acceleration does not make a trace abnormal. It makes you a hint. It's a hint that there's reduced Lycle. The second of our four, normal hypoxemia. The most likely thing you'll find is if you get early is just a slightly higher baseline than you'd expect. You're 41 weeker at 155 beats a minute. That is higher than you'd expect. You may have reduced variability, you may have absence of cycling, you may have accelerations, you may not. Don't forget this is a spectrum from very mild through to hypoxia, so it could be anything. But think of the picture. Why have I got a garrotic placenta, a poorly functioning placenta? Have I got preeclampsia? Have I got diabetes and macrosomia? Have I got endopregnancyeitis, so the placenta's just running out of steam? All of these things, what are the fetal movements like? Is there a hint that things are not quite as it should be? Now, in the UK, we have this terrible habit of calling meconium significant and insignificant. I hate that. I far more prefer physiological and non-physiological, because there's no such thing as insignificant meconium at 27 weeks. Light stay, yeah, that just doesn't make sense. But when you come across that, if you look at anything English, you may come across that. So, hypoxemia may have some bleeding, anything that gives you a hint that the placenta is not functioning very well. Now, this next example, I think, is a brilliant demonstration of hypoxemia. So if you look at the trace, she's 38 weeks, she's got preeclampsia. You've got here, this is on the 23rd of July. The baseline is about 130, give or take. The variability is 5 to 10. The accelerations are present. There are no decelerations. This trace is? Normal. Thank you. Somebody is brave enough to say normal. It is normal. 2 days later, the baseline is 145. The variability is 5 to 10. There are accelerations. There may be a decel. There may just be loss of contact. But forget the deceleration because it's not really a decel. This trace is normal. However, no, not that one. If you look at it, I've just turned it off. Oh. I am breaking the suspense. Right. So, if you look at it, so from that day, oh, for goodness sake. I think the battery's dying. Right. So, and then the next day, oh, you have a new battery. So maybe I should just not be impatient. Right. I've got a bottle, thank you very much. So, no, I'm just trying to go backwards. I'm trying to go backwards and forwards between two slides. It's not responding quickly. It's fine. It's fine. I've got it. So, that's normal. The next day you've got this one. But if you look at them, the baseline, come on, go back. I've just pressed the back button. Okay, yeah, you can see it. Normally I toggle, but you can see that very subtly over 2 days, the baseline has gone up. Okay? So only 3 things cause the baseline to go up. Maternal stress, fetal stress, infection. Okay, excellent. See, repetition, it works, doesn't it? 2 days before. Well, she's come in for induction. Yep. She's got preeclampsia at 38 weeks. So by any definition, preeclampsia. It's the old term for preeclamptic toxemia. Now, we don't obviously call it toxemia anymore, but PET in the because it differentiates from PE, which is pulmonary embolism. Okay, so she's got preeclampsia. She's got good going preeclampsia because she's got a PCR of 360 or something, I forget. And 2 days later, she's brought in for induction. So 3 things. The only thing that's changed, the baseline's gone up. 3 things. Mum stress, fetal stress, infection. It's not going to be infection. But it could be mum stress. Well, it could be mum stress. She's coming for induction. She's worried. You give her a cup of tea. You calm her down. Everything's fine. So you realize it's not maternal stress. Therefore, it leaves it to be fetal stress. So you spot that and you go, this is hypoxemia. I need to keep a close eye on you. And so you individualize the care. Because, now for those of you who are paying attention, this was done at 4 o'clock. And we used Propes, so it's the prostaglandin on the tampon. 4 o'clock, or 4:25, the Propes goes in. And at 4:40, that's the trace. She responded very quickly to the Propes, started contracting, and pushed not only the baseline up, but she started decelerating. Now, she was lucky that she started decelerating within the hour that we record the CTG, because if we hadn't, you'd have ended up with a stillbirth. And you can see there she's getting a variety of both chemo and baroreceptor decelerations. That's my signature. Decision to section was taken at 5 o'clock, and you can see the trace is just deteriorating minute by minute by minute. So this is evolving hypoxia, gradually evolving hypoxia on top of hypoxemia. So you've gone from normal to hypoxemia to gradually evolving. And if you look at the gases, this is a metabolic acidosis. Yeah, the PCO2 is relatively normal, but the pHs are close together and the lactates are relatively high.
Did you take the Propes out?
No, we left it. Yes. The Propes was taken out, the decisional section was taken, and yeah. But clearly she's still contracting very strongly without the Propes. She didn't take much to go into labor. So, how do you manage hypoxemia? Don't stress the baby more than you should. Delivery is required, either by induction or cesarean section, depending on what is going on and your discussions with mum. And if you find it antenatally, please, please, please do not give fluids. You cannot resuscitate a baby. You might as well give the fluids to the husband. You'll get as much response from the baby, and maybe more. Okay? Intravenous fluids do not improve CTGs unless and until you are resuscitating mother. If she's infected or ketotic, fine. But if she's neither infected nor ketotic and she's just had a McDonald's, don't give her IV fluids. It doesn't help. 3 out of 9. We're getting there. So gradually evolving. Essentially, the baseline is rising in front of your eyes. So as you saw the last one, it was hypoxemia, then gradually evolving. Variability is usually okay, and you may have few or no accelerations because you've got things just deteriorating in front of you. If it's in labor, a gradually evolving hypoxia can be, and usually is, normal to start with, as it stays within a parameter. Now, different guidance is saying different things. In the UK, there's a tendency to say 10%. I don't think that's much, because if you've got a baseline of 140, you can only go up to 154, or if you've got a baseline of 120, you can only go up to 132. But that's there, or is however I can. The usually answer to that is a scan. Let's get a scan, let's see what's going on. But if you've got gradually evolving antenatally, you need to deliver. You haven't got long. And depending on what your scan says, if your scan says there's no Lycor, Dopplers are awful, well, you're going to section. But if the scan says that your Dopplers aren't too bad, then you might just induce. But you individualize the care around the frequency of your CTGs and the space between them. If it's intrapartum, what do you do? Your standard resuscitating measures. So, change position. Consider hydration ketosis. Think about tocolysis, whether you need it or not. Reduce the syntocinon, and regular review until you normalize, definitely every 30 minutes, and think about delivery if it doesn't improve. So you've got time, you've got 30 to 60 minutes to really get things in place and make a difference. So that's gradually evolving. Then, if you do nothing or it continues, you get into chronic established. Antenatally, if you're unfortunate enough to have it, you're going to get, like Raj's trace, you're going to get a flat trace or undulating, poor baseline. If it's intrapartum, rule of thumb, if you've had the rise for 60 minutes, that's now established. Nothing, you've done your conservative measures and it's not changed. If you haven't done any conservative measures, then you might think about changing it. But consistent reduction in variability, chemoreceptor, that is compensated as chronic, and you've got decompensated is when it's just slowly but surely going crashing down. So this is a lady who came at 36 weeks with PV bleed, and you can see there, you've got a trace that I think the question last time was, is it pre-terminal? The answer is yes. Oliver was delivered shortly afterwards in thick pea soup meconium and sadly died 3 days later. You can see there, give water. It might work for you guys. I can see some of you are being resuscitated, but it's not going to work for the baby. Okay, giving water doesn't work. So that's antenatal. This is chronic established hypoxia in labor. Now the question is, what is going on? I'm not going to give you any more information. Why is this baby hypoxic? Anybody get it? Oh, somebody's pointing in the right direction. It's not anemia, but you're thinking along the right pathway. Why does it look like, do you say abruption? I heard infection, but I heard, yeah? Why do people say it looks like abruption? Don't forget it's a CTG. Don't just look at the fetal heart rate. Look at the uterus. What's the uterus doing? It's a high frequency, low amplitude. That is uterine irritability. Okay? 3 things cause uterine irritability: blood, pus, prostin. Okay? So prostaglandins cause uterine irritability, an infected uterus causes uterine irritability, and blood causes uterine irritability. Which one do you think this is? I can tell you this, she wasn't given prostin. Yeah, she's abrupting. Now, this is at 7:10 in the morning. I came to work at 8 o'clock in the morning, and I was absolutely livid. This poor young girl turned up at 2 o'clock in the morning. She's only had a BMI of 17 or something. She came in with a hard, rigid abdomen and PV bleeding and a normal CTG. What they were doing overnight, I do not know. But this is basically a baby that has succumbed to abruption and has got chronic hypoxia, established hypoxia in labor. The only answer, the management to this is? Thank you, deliver, ASAP, preferably 4 hours ago. Yeah, but not very well. So, established hypoxia, chronic hypoxia, urgent delivery antenatally, intrapartum, not including the last trace, but try and improve the environment. If it fails, consider delivery. And if it partially improves, shorten the second stage. Don't just say, oh, it's all better now, we can leave the second stage. If the baby has taken a hit, shorten the second stage. If urgent tocolysis is required, I know that Raj, you use intravenous GTN here, which I think is brave, because of the hypertension we talked about. Yeah. But, the spray is not expensive. And you can keep... Yeah. 2 puffs of spray under the tongue. You just say, this might give you a headache, but it shouldn't cause hypertension. The beauty is, it works instantly, and it wears off before you've delivered. It wears off. Or before you close the uterus. I wanted to mention it, we were talking about difficult cesarean sections. If you've got a transverse lie with no LICOR and you can't get the baby out, GTN relaxes the uterus, so easy, wears off, don't have to worry. The story I had, I was doing a delivery, a cesarean section, and I was having great difficulty with this transverse lie. And I looked at my ODP, who's the anesthetic assistant, and I said, can you get me some tocolysis, get some GTN? The anesthetist heard me, and he went off. as well. I thought, okay. And my ODP came back, gave the woman GTN. I delivered the baby. The anaesthetist came back in, and I said, what are you doing? He said, I'm about to give the terbutaline. I went, the baby's in the resuscitator. We're fine. Okay? That's because it takes longer to give the GTN. And also, it takes 15 minutes for the GTN to work. So there's a little story in that. So if it's decompensating, urgent delivery. Okay, acute hypoxia. So we're more than halfway. Excellent. Then we get examples. So prolonged deceleration until recovery up over 100. That's the definition. Do not forget that a bradycardia, definition of bradycardia is 10 minutes. So it's usually only given in retrospect. Until then, it's a prolonged deceleration until recovery. Now, there are two types, if you like, of your bradycardias. You've got one that comes out of the blue, preceded by a nice normal CTG, good variability and so on, and just comes out of the blue. The chances are it's going to recover. But you have to do, as Raj said, you've got to get rid of your three causes: cord prolapse, uterine rupture, uterine abruption, placental abruption. So you do your VE, you put your hand in the abdomen, and you just make sure that you haven't got those three causes, that you haven't got a hypertonus, like the one that we had earlier. Hypertonus, give a GTN, and it removes it, and you transfer to theatre. Do not be lulled into the nice guidance that says that you only start transferring at 9 minutes. A lot of people interpret that the rule that says you start delivery at 9 minutes, therefore you transfer to theatre at 9 minutes. How long have you got with an acute bradycardia before you get brain damage? I've told you. 10 minutes, yeah? So if you start moving at 9 minutes, it's too late. It's too late. That's why in our unit, we have this emergency transfer system, which I think is brilliant and saves plenty of lives. But whatever you do transfer to theatre, you transfer to theatre. And you commence delivery by 9 minutes. So you're in theatre, and if it hasn't recovered at 9 minutes, you get on with it, and you deliver the baby by 10, hopefully. If it recovers, you can return to the room, because it's probably just a cord accident. And as I'm sure those of you who've done transfers to theatre and so on with a bradycardia, by the time that you've got mum onto the theatre bed and you moved her and tossed and turned her, baby's come off the cord and it's fine. And it's looking at you and it's having a good laugh. But if before you've had this bradycardia, you've got no variability, and then you've got the bradycardia, deceleration, then you can pretty much guess it's not going to recover. You just need to deliver. You just don't wait. You crack on. So here's an example of an acute hypoxic event. So you've got your normal trace with good variability, and suddenly there's a deceleration out of the blue, which is almost certainly an intrauterine cord accident. Midwives recognized, tossed and turned. You can see the variability during the deceleration is okay, and by the time I turn up, way too late, must be very slow, the fetal heart is already recovering. So you can rest assured, let the baby, you'll expect that baby to do some intrauterine self-resuscitation, and what that usually involves is you'll see the baseline is slightly higher than it was earlier. So you can see there the baseline's there about 120, and then it takes 140, and you'll usually see it settle down over 30 minutes. So that's a very healthy baby who encountered a sudden cord accident. And you can see here biphasic accelerations. You can see the cord compression within those accelerations, which is not a surprise. A different type of acute hypoxia is this one, which is your saltatory trace. So this is a baby that is in extremis cardiovascular instability, and it just does this all the time. And you can see here they did a scan, no LICOR, and they just put continuous CTG. Straight after that, I think that's on the next slide, that's what it went into. Okay, so that trace finishes at 5:35. That trace starts at 5:40. And you can see how a baby goes from a compensated saltatory trace to a decompensated pre-terminal trace. Very lucky to catch that one, and the baby did survive. And if you're confused, it's because she went from room 6 on day assessment to room 6 on labour ward because theatre was occupied. But she delivered and she was fine. So that shows you how a saltatory trace is not, or an excessive variability is not a good thing. It is a compensated cardiovascular instability followed by a decompensated trace there. Subacute hypoxia, you remember we saw the core compression. Well, basically, you can have it in the first stage or second stage, and it's a subacute, prolonged partial. Subacute is probably a better term because prolonged partial assumes you have to wait a certain amount of time, but subacute means that's going on now. And the baseline rate, the heart rate is below the baseline for longer than it's at the baseline, and baby is not allowed time to recover. The classic situation is core compression, which is what we had before. Sorry, it's this one. There. So you remember that one? That was the core compression. So that's the classic one that you get time and time and time again. And as long as the baby doesn't, as long as you've got recovery in between, then you're fine. If you have no recovery or little recovery, then baby is going to suffer. An alternative is head compression. And you can see here, when you've got a trace like this and saying, is it accelerating or is it decelerating? What do you look at? Thank you. Somebody's been listening. Variability. If the variability is not good, it's decelerating. If the variability is good, it's accelerating. Now, that doesn't mean that you can say, oh, it's normal, leave it alone. You have to find a good heart rate. But here, we have a clear poor variability, and we've got decelerations which are occurring with pushing, and this is head compression, which mustn't last longer than 60 minutes, or if infection, 30. Okay? So don't let it last too long. And look,
60 minutes too long.
60 minutes is too long. That's 30 minutes.
This baby, 60 minutes might be too long.
Yeah, it might be. I'm saying no more than. Don't forget, the 60 minutes is not a target.
Yeah, if you make a decision and you would target to deliver in 30 minutes, you might end up getting the baby out beyond 30, but you'll be still within 60
It's like these 30-minute audit times and whatever.
Yeah.
It's not a target, it's a limit. You must not go beyond. It's like a speed limit. Okay, nearly home. 7, infection. Pretty obvious, really. So it could be maternal or fetal. We've had a lot of COVID traces. When I'm talking about COVID, I think it's very important to remember that if a woman has COVID in pregnancy, even if she's not hospitalized, she needs serial growth scans because the COVID protein, spike protein, sits in the placenta and interferes with gas exchange. There's an increasing evidence base of cases where there's an increased stillbirth rate, growth-restricted rate, and preterm delivery rate in women with COVID who've not been hospitalized. So just caught COVID whilst pregnant. So just be mindful of that. Anyway, maternal pyrexia, abdo pain, prolonged ruptured membrane or offensive liquor. But please don't forget, if a woman's come in for induction and had intervention, multiple VEs with intact membranes can also cause infection. The bacteria can go transmembrane. They do not need ruptured membranes. The ruptured membranes makes it easier. But if you've got somebody who's been in induction for several days, they can definitely have infection. And one aspect that a lot of people don't realize is new onset meconium in labor is not necessarily hypoxia, but maybe infection. Because the first thing the baby does when it's infected is it poos. So don't forget, if you get new onset meconium, think infection. Also, if the baby doesn't respond to scalp stimulation, that also might be infection. And as we said, so what you're going to find, so CTG, the baseline may be higher, the variability may be normal. It's a trace where you look at and you just go, don't like it. Can't put my finger on it, just don't like it. Think infection. If you're not sure, think infection. Why? Because infection kills. It damages, especially infection plus hypoxia. Let's try and avoid that. We talked about infection halving the time. Don't forget maternal antibiotics, essential for mum, do not help baby. They will not improve the neonatal outcome by giving mum antibiotics. You're better off giving the pediatricians a naked baby, i.e. no antibiotics, than one that's had an hour or two of antibiotics. That's different to antibiotic prophylaxis. But treating an infection will not help things. And consider an operative delivery if delivery not imminent. So this is one of those traces. Mum comes in, temperature's 36.8, her pulse is 114. Baby's heart rate, this is at term, is 160, which is a bit on the high side. Variability is neither here nor there. It's about 3, 4, 5. No accelerations. FH does not respond to touch, is what the midwife wrote. Did a VE, 4 centimeters, nothing happened. And this is one of those traces. No accels, no decels, just not very happy. The baby then went on to get very infected. Trace became very obvious. But there's enough information there to raise my suspicion. I'm not saying, oh, infection, deliver. I'm saying, let's keep a close eye. Let's do some white cell counts, CRP. She's in early labor. It might be of benefit and give us a hint as to whether we're going somewhere that we don't want to be. But also, at the earliest signs of deterioration, I might intervene sooner rather than later if I think there's an infection plus hypoxia. Anemia. We talked about sinusoidal and pseudosinusoidal. I'll show you a pseudosinusoidal. So, consider if reduction in fetal movements, possibly associated with abdopain with fetal maternal hemorrhage, we had before, but also rhesus disease and parvovirus. So if there's a viral infection in early pregnancy, think of that. Pseudosinusoidal, as I said, is not anemia. It's technically hemorrhage and is associated with ARM and vaginal bleeding or abruption. And what it is cardiovascular instability. This baby's hemorrhaging, and it's trying to stabilize its heart rate, and it can't. So there's anemia, chronic anemia. And as I said, the only thing the baby needs is blood. Do not deliver the baby before you have blood. If you do so, that baby will die in front of you, or be damaged if you're lucky. Okay? You are much better, as we talked earlier, transferring the baby to a unit that has blood, or just giving the baby O-neg if you have some O-neg in your unit. So, baby must have blood, and blood on the labor ward before delivery. Here's another one, a bit more established. So you can see, as I was saying, the difference between pseudosinusoidal and sinusoidal. Sinusoidal is a 3 to 5 hertz per minute, so 3 to 5 revolutions per minute, and the amplitude is 5 to 15 beats, no more. As opposed to pseudosinusoidal, which is this one, where you can see it looks very similar. Well, not really. But it's going up and down. What you're getting is a much broader, deeper change, but you're still getting 3 to 5 hertz per minute. And that is quite a lucky catch. The registrar came at the arrow, they marked the trace on the left. They said, yes, go and get the prostin, the propes. The midwife left, came back, looked at the trace, said, I don't know what's going on, I don't like it. The registrar came back, I said, she looked at the trace, she said, I don't know what's going on, I don't like it. They did a 2-to-2 transfer, which is an immediate, and our 2-to-2 transfers is like cardiac arrest. So anybody can pick up the phone, student midwife, whatever, they dial 2222, 4 twos, and they say, emergency transfer, birth center to labor ward or room 2. So that means that the obstetrician, the pediatrician, the anaesthetist, they all meet in theatre. So there's none of this wasting time going to the patient and then moving. Everybody goes to where the patient needs to be. The patient's in theatre, and then you ultrasound the baby, and you go, heart's fine or whatever, or in this case, you just deliver. They opened up the uterus. It was full of blood. So she had just randomly abrupted. So anemia, as I said, delivery is not a Cat 1. It's Cat 2 or 3, okay? You need to be in the right place with the right people, and you need blood. Do not deliver unless you've got blood. Unlike an acute If you've got a pseudosinusoidal, you just need to deliver the baby because the baby is hemorrhaging. Uninterpretable, that's the last category. And so what could we have? Poor signal, uncertain baseline, or accelerations in the second stage. So this is a lady who came in with reduced fetal movements. And people go, well, what's wrong with that trace? What you're all doing is you're normalizing. I would ask you, hand on the heart, where's the baseline? Is it 140? Or is it 120? And how do you know? And how can you be sure? And are they accelerations or are they decelerations? The variability is reasonable, but there is no clear, sustained baseline in a woman who's presented with reduced fetal movements. If somebody presents with reduced fetal movements, you want a nice, clear baseline with accelerations, otherwise it's not normal. And you can see the outcome in the title. She came back 10 days later with an IUD. So I put up there because this was passed as normal, and a lot of people still say, oh, the baseline is 120 and accelerating. I say, but you cannot guarantee it is 120, and there are no clear accelerations. So don't normalize, be careful. This is a wonderful trace. This is a trace in 2005 of a lady who was 29 weeks, who was reporting preterm labor. I was woken up, as you can see, at 4 o'clock in the morning, and I said, and the information I got was a 29-week who's come in, she's contracting, and she's decelerating with every heartbeat, every contraction. So I said, I'll meet you in theatre. And we delivered the baby. Big mistake. If only I knew then what I knew now. If you look there, every single one of those contractions is fake. She is doing Pilates. She's a slim girl, just doing Pilates. She didn't call it Pilates, but I'm saying it's essentially Pilates, just tensing her muscles and talking, tensing her muscles and talking. You can do that. That's what I'm doing now. I'm tensing my abdominal wall, and I'm tensing my abdominal wall, and relaxing, tensing, and that's what that is. Straight up, straight down, straight up, straight down. Those contractions are fake. What's also happening, external monitoring, fetal to maternal, to fetal to maternal, to fetal to maternal. Every time she changed her abdomen, it changed the angle of the transducer, and it picked up the mum's pulse. The giveaway, I'll let you into a little secret, most CTG machines take 3.75 seconds to work out a heart rate. So every time you go from maternal to fetal, there is a gap because the machine goes, whoa, what happened? Oh, yeah, that's what happened. And it gives you another heart rate. And you go, oh, what happened again? So you get a gap in the recording. And that is all fetal, maternal, fake. The other story behind this, I delivered her, 29 weeks. She came back 2 years later, at 29 weeks. Guess what? Contracting. But not only was she evil, she was stupid. Because she said, oh, Mr. Waterstone, you delivered my last baby at 29 weeks. And I went, hang on a second, hang on. I don't believe in coincidence. What's going on here? And so what did I do? What would every good obstetrician do? And we're not talking about duty of candor here, okay? No. I went back to her notes, and I looked at the previous CTG, and I went, isn't that amazing? They look exactly the same. But I had 2 years seniority then, and I went, I said, your muscle walls are contracting, your womb's not contracting, you're fine, relax, go home. And she did. She eventually delivered at 39 weeks, but 35 weeks. But it's quite incredible how some people do this, and I still don't understand it. Anyway, so beware, fake contractions, maternal heart rate, maternal interference. Maternal pulse in the second stage. Ooh. What do the new NICE guidelines say you should be checking? Every 5 minutes you should be checking the maternal pulse on a CTG. Give us a break, as if you're going to do that. But, is this accelerating or decelerating? Look at the variability. Look at the variability. Is the variability good or bad? Good. Good. Therefore, it is highly unlikely that somebody with good variability is going to be at 160 decelerating. Makes it unlikely. I choose my words carefully, unlikely. It is far more likely that it's going to be at 120 accelerating. Now, it's not easy to see on this one because she's contracted so much, but look at that. Look where she stops contracting. What happens to the heart rate? Oh, thank goodness. I've had a break. That is all maternal. That was an hour and a half of maternal trace in the second stage. And surprise, surprise, the baby came out not very well. So, that is not allowed. And the new guidelines say every 5 minutes you should be checking. Now, I don't think you need to check it every 5 minutes when you've got a continuous trace. But if you're not sure, stick a fetal scalp electrode on. And what I say is, as soon as you start the second stage, the active phase, immediately take mum's pulse, shut your eyes, listen to the heart rate. And make sure that what you're feeling and listening are different. Okay? Because what you're listening is the fetal, hopefully, and that's what's recording. So poor signal, consider gestation, appropriateness to CTG, repeat CTGs until normal. Fetal scalp electrode, yes, please, especially in obese women and twins. If the trace is hypoxic, early recourse. If you're not sure the baseline, check everything. And if the variability is normal, it's not going to be hypoxic, work around it. It'll be fine. If you get accelerations in the second stage, yes, you can get some adrenaline junkies, but the far greater majority are going to be mum and not baby. So check it out. The rule of threes, mine is ever slightly different, but it's still 15 minutes. So you can see here, with the rule of threes, you have 15 minutes to deliver baby, which means you've got 5 minutes of brain damage. That is accepted in UK law. It does require a very tight team. In our units, we can do 8 minutes, even without what we've now got, which is emergency transfer. You can see already you lose 3 minutes of delay by transferring to theatre and meeting in theatre. Now, people say, well, if you do an emergency transfer, surely you have to deliver. The answer is no. You just say to, as you're transferring, this is probably a mechanical or technical issue. As soon as we get into theatre, I'm sure everything will be fine. But if it's not fine, then you need to be in theatre because you need to deliver. But if it's fine, we'll do a trace. Happy days, we can go back to the room. Okay? No problem. And I once took a lady to theatre 3 times and eventually gave up and delivered her thankfully by then she had a ventouse and baby was fine. Dot C bravado, there you have it. You're very familiar with that. I'm not going to bore you with it.
Excuse me, Dr. Mark. What is the 2222 emergency transfer? What do you mean by that? The previous slide?
That is what we've instituted in my unit. When you have a bradycardia, or a sudden, you lose the heart rate, or you can't find the heart rate, you do a 222 transfer, so it's like cardiac arrest.
Oh.
You phone the switch. We do it by switchboards. We have pages. But if you have your, what do you call it? Public announcement. You can have a public announcement. So everybody goes to theatre rather than sending the obstetrician to the patient. Everybody goes to theatre to the patient.
Okay, that's what you mean by 2222.
Yeah,
Okay.
that's the 222 is the cardiac arrest bleep number. Sorry.
Okay.
I tried my best to transfer this to India, but that was one of those things I couldn't transfer. It's the only thing, if you take away nothing about this, you need blood before you deliver. If you do not have blood at delivery, baby will die. This baby's HB was 98, so it needed blood. So why transfer the theatre after ARM? Why did they do an ARM? I do not know. But she transferred to theatre after ARM because she bled. Not surprising. Blood plus. So she had an abruption, and she had a previous early abruption a week before, ongoing abruption, and she hemorrhaged. Good. Next one. Some of these will be a journey for me because I have, as I said, I have 150 different cases. I can't remember them all. So when I look at them, I'll be just going, okay. Lovely. Okay. So 30-year-old paranaut, she's a civil servant. BMI was 27. She had an uneventful pregnancy. She was admitted at 41 weeks, for 10 days beyond, in possible labor, contracting 2 and 10, and she was booked for induction of labor. She'd already been booked, because in those days, our inductions were at 10 days beyond. They are currently 12 days beyond, and now they're going back to 41 weeks. And soon they're going to go to 39. But that's where it is. So her V at 8:05 was she was 3 centimeters dilated, -1, easily ARMable. 143 was the FH, and the plan was to mobilize and then go to the midwifery-led birth center. Sounds reasonable? Yeah. Low risk, nullip, BMI is 27, everything fine. She has a V at 9:55, was pretty stable at 144. And she went home to await events. She reattended. Shouldn't send women home, should you? Look at that. She reattended the next day, or later that day, that evening, in labor, and the heart rate was 188. So, what's happened? The heart rate has gone up. 3 things. Maternal stress, fetal stress, infection. Do we think this is maternal stress? Maternal pulse is 98. It's possible, but it's not going to be sending the baby to a heart rate of 188. So what's the most likely? Infection, isn't it? What else? With a heart rate of with a heart rate of 200, what else could it be? Yeah, it could be an SVT. Anything over 190, 180 perhaps, but anything over 190 could be an SVT. So you want to think of that. But an SVT will have no variability. It'll just be bang, bang, bang. So maternal temperature, 37.8. Well, it's pretty obvious then, isn't it? She's cannulated, they give her fluids, and they did a VBG just to check her, and her lactate was 1.1, so she's okay. And you can see here at the end, the trace was suspicious, as they called it in those days. This is in 2020, not that long ago. So fluids were started. Transfer to labor ward. What's your plan? What are we going to do? Well, we need to see where we are in labor. Because if she's still 3 centimeters and the baby's got a heart rate of 188, I can guarantee you, if I remember right, what do most people do when mum's temperature's up and the baby's heart rate's up? Give paracetamol. Yes. And what does paracetamol do? Hides what's going on. The baby is not going to get killed by pyrexia. The damage is not recognizing that mum is deteriorating. Because if you give paracetamol, when the temperature is only 37.8, you're going to hide the rise. So just think twice before you give paracetamol automatically. Just think twice. I'm not saying don't give it, but don't forget what it's going to do. It is going to mask the next rise in temperature. Of course, if she's got a temperature of 40, you need to give it for mum. So there she is, admitted, IV paracetamol, and the heart rate is, as you can see there, settling a little bit to 165. Mum's pulse is 115, 110. Temperature is the same. She has a V at 10 past 10, and she's 4 centimeters. Has an ARM at 10 past 10. What do we notice? At 20 past 10, what do we notice when she has the ARM? You can see it's on the far right of the trace. Yeah. The baby's responded to the ARM. Okay, so there's fetal scalp stimulation. This baby is not hypoxic. Yeah, nice response to the ARM, but we're not worried about hypoxia. The variability is okay. What we are worried about is infection. At 4 centimeters, in a nullip, spontaneous labor, we've got 6 hours, 8 hours. If you go by nice, it's half a centimeter now. That's mum. That's mum, yeah. So on this one, you've got the maternal pulse and the baby's pulse. So you can see, if you look, yeah, it doesn't actually say it, but you've got the pulse reading. On the Toco line, you can see the mum's pulse is written down, 102, 104, 105. Yeah, but the trace is yeah. So you've got maternal trace and fetal trace. You can see here, this also demonstrates nicely in the middle section what happens when you lose contact and you go from fetal to maternal. There's a gap. You will almost always have a gap between the fetal and maternal trace when they go from one to the other. So look for it. If you see a gap, that's maternal in between. So what else are we seeing? We're seeing the baseline rate is slowly coming down. Okay, so mum's pulse, temperature is probably coming down, hopefully. Pulse is still 110. Seen by a registrar who knows a bit of physiology, but not all of it, unfortunately, and says baroreceptors. So we are getting what looks like some decelerations. And I don't know what your machines do, but you see at the top line there, there's a question mark. You see that? Right at the top, where it says FHR1 pulse, there's a little question mark. And what that is saying to you, the machine is picking up one heart rate from two transducers. So if you've got a twin trace, look out for it on the top and make sure that you're not just picking up one trace. But we know that because it's going down and it's it looks like you're getting core compression, which is then recovering. So this is baby loss of contact. For SSE, trace looks normal. So the plan is to put a fetal scalp electrode on because of loss of contact. They do that. And what this section of trace at the end shows nicely is not what people often call fetal ectopics. It's not. It's interference from the FSE, the scalp electrode, on a bit of membrane or on a bit of cervix, and just getting a signal like that every now and again. Okay, it's an artifact, and you can look between it. You can still see the variability here is about 3 to 5. It's not very good. She's now contracting spontaneously 1, 2, 3, 4, 5, and 10. Beware the nullip who contracts spontaneously 5 and 10. Something is driving this uterus to contract. Blood or pus. In this case, it's infection. So she's now 6 centimeters. Again, loss of contact. More loss of contact, out to the toilet. So now they've given us some cefuroxime. That's what we use now. So they've realized that she's probably got an infection. 7 to 8 centimeters at spine, so she's progressing well. The trace has settled. The trace is now normal, which is why it's so important that when you're reviewing traces, you review the whole trace and you see where they come in. So when you're doing handovers, if you do handovers, you make sure that you don't forget that at the beginning this woman came in 6 hours ago with infection, very clear infection, and it gets lost in translation as the labor progresses. You can see here now, you've got lots of positive signs here. What have we got? We've got good baseline, good variability. What's the variability doing? Cycling. Yeah, low, high. You've got accelerations. This is not a hypoxic baby. Axillary temperature, 37.6. And that must be that she's 38.6 if the axillary is 37.6. So more IV paracetamol without recognizing that, in fact, we've got a worsening infection. Mom's pulse is 111. Another beautiful, beautiful fetal response to scalp stimulation. You can see there the acceleration at the VE, 9 centimeters, clear Lycor. Progressing nicely. 9 centimeters. So at 3:30, she's 9 centimeters. At 4:30, she's 9 centimeters. What do you think she's going to be at 5:30? Any guesses?
40.
No, 9 centimeters. This is not Disney. Anterior lip. So the registrar says, give Synto. So you've now got an infected baby. You've got poor progress for 3 hours in a nullip, so you've got secondary arrest. And it's at the spines and OT. You should be thinking, how far should I push this one? Now, you might get a vaginal birth, but is that the aim of the game? And as we say in England, I'm sure you say here, the aim of obstetrics is healthy mother, healthy baby. It's not a vaginal birth. So, 6 o'clock. So at 5:30, she was 9. At 6 o'clock, she's still 9. Good response to scalp stimulation. They're going to commence Stinto, second stage. Now, it's interesting because she was contracting 5 and 10 earlier. Why is she not contracting 5 and 10 now? Surely it's just going to get more and more. Maybe the uterus is infected as well. But there's a lack of joining up the dots. So we're now involuntary pushing, V, lip pushes over the maternal effort. I would urge people not to push lips over in a nullip. A multip, yes, but a nullip, you're just creating trouble, and you're going to get a difficult instrumental. So now she's got chemoreceptor decelerations, as well as barrow, by the looks of it. She's pushing. New midwife, review of CTG. Normal second stage trace. I'm not quite sure. I never liked that term because I don't think they could quite know what it means. What it means to me is that she's decelerating. This is the midwife handover. She writes it down. 4, 6, 8, 9, 9, 9. Anterior lip, anterior lip. So from 3:30 to 4 hours later, she's made half a centimeter. Where is this heading? Not a good place. Now, prospectively, if you see that, you come in, you've just got to be going, what's going on? Surely we've just got to give up. So temperature 36.8, pushing, very uninterpretable trace, but now you can see the baseline's gone up to 170 at the end with decelerations. What kind of decelerations are those? They are synchronous and they are mirroring. So that's head compression, yeah? Which you'd expect because she's pushing. Reg review, possible infection. I'm not sure where the possible comes in, but anyway. IV antibiotics, an increase in temperature on IV antibiotics, and increase in temperature and CRP. So clearly, I think this registrar had been listening to me. Mustn't stress the baby too much. Baby's not hypoxic, so hand over to day team. This variability is getting a little bit concerning, bearing in mind she's now 9:20, so she's now 6 hours following 9 centimeters. Seen by consultant, ROT to ROA, molding +1, difficult to rotate as patient, lots of discomfort for trial in theatre. So she's taken to theatre. What is important before we do a trial in theatre, do you think? I'm sure the same it applies in India just as it does in the UK. Discussion with mother. Because by definition, a trial has a failure rate. And if it's got a failure rate, you're exposing mother and baby to a fully dilated cesarean section after a failed instrumental, as opposed to a possibly difficult cesarean section, but without the failure. Bearing in mind baby's infected, mum is stuck, and guess what's going to happen to the uterus afterwards? 6 hours and 9 centimeters. She's probably get a massive PPH. So I think it is mandatory to have a discussion, give her the choice. Do we continue or do we not? They do a forceps delivery, and the APGARs are 9 and 9. And they got away with it. But they shouldn't have done. Not all my traces have a bad ending. I was told off when I started doing this, all my traces had bad endings. And if we look here, baby was... 4.3. Yeah, I know that's a lot in your country. In our country, 4.3 is, it's not so bad. But it's still big. And you can see there, base deficit pH 7.2, 7.3, PCO2 7.5, 4.8, and lactate was only 5 and 3.9. So this baby had a huge reserve, was very healthy, and they were lucky to get away with it. Excellent. Next one. So with your permission, I'm just going to I'll keep going till 9. Yeah, yeah. Good. That's what you paid for, so that's fine. Okay, 25-year-old housewife, married to a chartered accountant. When I did my research a long time ago, I found that their occupation and the social standing had a big impact on their outcome. That's why I used to write these things down. But anyway, she's a nullip. Uneventful pregnancy, however, head 4/5 palpable at 37 weeks. Fundal height was okay. She's 39 weeks, she's admitted with contractions, but no SHROM. The cervix was very posterior. Unable to reach the os, the head was at the spines. She was given pethidine at midnight, the V at 5:45, 4 centimeters spines. The forwarders were left at mother's request. So, any questions? Any comments? Low risk? Straightforward? Yeah. Maybe a bit worried about the higher head. Head's at the spines, but we'll see. She has an epidural at 7 o'clock. At 7:30, she's 6 centimeters dilated, ARM and clear Lycor. The trace at 8:30, post epidural. Baseline 120, variability 5 to 10. Looks like there's a bit of cycling, acceleration, some core compression, but she's had an ARM, so you'd expect core compression. This trace is lovely, normal. Don't be so puzzled. It's normal. Wait to see where we go. At 9:30, she's 9 centimeters. What can we see on the far left-hand side?
Maternal.
Well, it could be maternal, or it could be, because you can see it in the middle, and we can see it on the right-hand side. You can see some core compression, possibly. At 10:40, and in fact, on the far left-hand side, that's not maternal, because maternal pulse is 114. So in fact, you've got a core compression, deceleration down to 70 beats per minute. Quite a pronounced core compression on a lady who has a high head, potentially. She starts pushing. So, this is the trace at 11:10. The baseline is 125, 130. Variability is 5. Some acceleration, some core compression, deceleration. Mum starts pushing. Eventually, she starts pushing. Right, pushing. Oh. Pushing commenced. Baseline starts at 100, goes up to 120, or does it go up to 140, or is it 120?
It goes up to 140. So I think there are decelerations.
Okay.
Because the baseline went up to 140, and then it goes up to 150, 160.
Okay.
So what we see on the other side as 120 is likely to be a deceleration. I don't know.
Possibly. Have a look where she's not contracting. When she's not contracting, just above CTG 4, the baseline is 130. And she starts contracting, it goes up to 160. It comes down to 130, it goes up with the next contraction. It goes down, it goes up with the next contraction. Yeah. It's maternal pulse. Her pulse was 112 when she wasn't pushing. Now it's 120. So this is maternal pulse that you're getting. Now, what do we see here? Reg called immediately. What do we think happened just to the left of that EPV? Why has these accelerations suddenly stopped and then gradually gone up? The heart rate has gone higher and higher. No, she is not yet delivered.
It wasn't an acceleration in the first place. That's what I think.
Why was she told to stop pushing? No, you're not going to, possibly. She's still contracting. So if you've got uterine rupture, your contractions go. She was told to stop pushing, and then her heart rate went up and up and up and up. Why did it suddenly go up and up and up and up? What did they tell her that made her worry? Well, they haven't got a clue about baby's heart rate. They're not measuring it. Cord prolapse felt. Did you say it? Well done. You get the prize. It's your turn next. That's the prize. Cord prolapse. Beware the high head. And for the love of God, monitor the baby. Because if you'd monitored the baby, you'd have got cord compression, cord compression, cord compression. So the cord prolapse, stop pushing, mum's pulse. V performed due to delayed second stage, check position, cord felt at 12:40, just before she was told, stop pushing. Advantage delivery, male infant, placenta membranes, syntocinon. And you can see there there's cord, the diagram with the cord felt at 11 to 12 o'clock. Gases, 6.93, 7.32. So, when you look at that, acute or chronic hypoxia?
Acute.
Yeah.
Acute.
Acute, yeah? The venous is 7.32, the arterial is 6.96. What do you think the trace was before? Had they been monitoring the baby, do you think the trace before would have been normal or not?
Which one?
Because the venous is normal, the trace was normal, likely, yeah? Because the venous is completely normal, 7.32, base deficit 6. So it's absolutely fine. So that's a completely consistent cord gas of a cord prolapse. Excellent. Next. Only 147 to go. I'm joking. Midnight for me is 3:30 in the afternoon. That's good. I'm fine. I'm waking up now, and my jet lag was a bit back. Okay, so 38-year-old Nulip, limiting English, she only spoke Punjabi. Her BMI was 23. On the GROW chart, that's the gestation-related optimal growth. That's the Gap and Grow program. So it's a personalized growth chart taking in BMI and ethnicity. Her baby was on the 75th to 90th centile. She apparently had a low placenta to start with, which resolved by 34 weeks. Language line was used in antenatal clinic, and at 40 weeks she had a sweep, and a V after, the fetal heart rate after the V was 100 with quick recovery to 136, as we were saying earlier, about you get a deceleration when you, instead of fetal stimulation. And this is her CTG on the labour ward. Blood pressure was 148/92, urine was NAD, her pulse was 120. What else have we got? So we've got a baseline heart rate of 140 to 145, variability of about 5 to 7. Accels, yes. Decels, no. This trace is normal. However, we cannot ignore the fact that they heard a deceleration earlier. So they're going to continue it, no doubt. But she's a little bit hypertensive. 148/92. That was the CTG. Nothing written in the notes after CTG was analysis, but it was a normal trace. She comes in 2 days later. I think that's 2 days later. Yeah, so that's the 11th of February. 4 days later, she comes in. Contractions since 8:30 that morning. Fetal movements were felt. No SHROM. And she was asked to come in. She comes in an hour later, and this is the trace an hour later. She has a VE, and you can see it there. What do we not see at the VE? What does the baby not do? It doesn't. No response to the scalp stimulation. Yeah? Unlike the previous ones. Thick meconium, CTG, where they put suspicious, 9 centimeters. Query OA, transfer to labour ward. So at the end of that, we've got some core compression with overshoot. More core compression.
For variability.
Was an FBS indicated in this trace?
No.
Why not?
Because
He lost hair. Indian baby. Yeah, I know. What can you do? That's not why it wasn't indicated. Do you know, when I was a young registrar, I actually did an intrauterine haircut on an African baby through the speculum. I got scissors. What was I doing? I got the FBS. It was normal. But the baby had a... I would never do that again. Why was an FBS not indicated? 2 reasons.
It's a meconium with
Yep.
a suspicious trace. Already variability is reduced.
Yeah.
So fetal scan may give a false reassurance and we may
Absolutely.
continue.
Absolutely. The thick when I used to do FBSs, the one rule was do not do FBSs if you've got thick meconium, because they are. The problem with meconium is meconium aspiration, and the FBS is not going to tell you whether you're going to get aspiration or not. That is a sudden shock. But equally, this trace is awful. What did they not do, I bet you, that you should do every time you look at a trace? They didn't look at the previous trace from 4 days earlier, which was beautiful. Nice baseline, good variability, and 4 days later, you've got this. So there's only one option, which I would say is section. Do not make this baby worse. Now, you may say, but she's 9 centimeters. Why would you section? Why can't you just let her deliver in an hour? You don't know that. I don't know that. I mean, we've all seen 3-4 hour second stages. This baby is not going to survive. We talk about reserve. This baby has 0 reserve. It is going to fall off its perch very quickly. So this woman should definitely be given the option of a cesarean section without looking for anything else. You've got no variability, no response to scalp stimulation, thick meconium. How much more information do you need? So B, biconsult, OP at spines, +2, +1, +2. Biphasic D cells, significant MEC, suspicious, as FBS not feasible for trial in theatre. I'm not quite sure. Do you want to speak to Lives? Go away. Sorry.
Must be from home. You better check.
It is. It's my boss.
You better check.
He knows I'm here. So FBS not feasible for trial in theatre. And you can see there, fully LOT, +2, caput molding, blades applied, delivered at 16:32 with baby delivered at 16:33. Now, why in heaven's name did that consultant do that instrumental delivery? He wrote, I would prefer an FBS before commencing rotational. He did the Keelans, but he decided that it would be much, much quicker and safer to do a Keelans in his hands. He is an extreme expert at Keelans, and as you saw, it didn't take long. Did the Keelans add any insult to injury? Look at the gases. Is there much of an acute element to this hypoxia?
No.
The venous pH is 7.06. The arterial is 6.92. This is almost totally chronic. The PCO2 is 11. It's up a bit, so there's a tiny amount, but not much. So the instrumental delivery didn't add much insult to this injury in that consultant's hands. But personally, I would have done a cesarean section. But he knew that that was the issue, and that's why he wrote what he wrote. Full respect for him. Excellent. We're doing well. We're cracking through these. Sorry, I've got this.
You need a break?
No, I don't need a break. No, I do not need Zumba. Sweet lime.
Have a few.
Oh. Okay. Must be one of yours. Induction at 39 weeks. Admitted for induction. Because the baby was on the 90th centile. Over the 90th centile. I mean, I don't know what your policy is in India, but there's a huge debate on large foetate babies, not diabetic. And I don't think anybody's got the answer yet. I think there's lots of trials coming out. Anyway, so pre-propes, which is what we use. This is the CTG. So, what have we got? We've got a baseline of 140. We've got a variability, which is cycling. A bit better on the left, not so good on the right. It's about 10 on the left, it's about 5 on the right. Do we have an accelerations? Well, it looks like we've possibly got an acceleration on the far left. Any decelerations? Oh, you spotted it. I thought that was subtle. What kind of decelerations? Chemo or baro? Forget the lateness. Look at the edges. Straight down, straight up, or is it slow and slow? Look at the one on the far right, on the middle. It's straight down, straight back up. Okay, core compression. Quite pronounced core compression. It would be very unusual on an antenatal trace with good variability to get chemoreceptors. Very unusual, because why would you have good variability and yet chemoreceptor deceleration? It's far more likely that you've got baroreceptor. Okay, so we've got very, very pronounced. I mean, that's a, what's that? That's a 2.5 minutes deceleration. What are you going to do? Continue the induction?
Well, she already had propose.
No, pre. Hasn't. We do CTG first.
Yeah, so let's.
Propes.
We'll continue the CTG,
Okay.
and then we make sure that she doesn't get this prolonged deceleration.
Okay, that's one option. Ultrasound. I like the way you're thinking. Why are you getting the ultrasound? Yeah. The question is, why is she decelerating? Remember, we're no longer pattern recognizing. We are now working out what is going on to this baby. We have got evidence of cord compression on an otherwise totally normal background. It makes zero sense. That is a very big decel. So I would either get an ultrasound or I wouldn't induce. Because guess what? It's going to get worse. Yeah, you're thinking the same way I am. It's going to get worse. So,
Well, we don't know whether it will get worse. That's retrospective.
no, it's prospective.
Well, now
It's likely to be, no, I'm saying it's likely. I'm not saying it is. I'm saying it's likely. Now, it may not. It may get better. It may be that the baby moves away from the cord, but it's likely to get worse. Now, this is why the CTG appearance. Is it hypoxic? And if then what? What have we got now?
deceleration is reduced very.
That's the CTG, finished at 510. The baseline is 140. This is the CTG straight afterwards.
After propose.
No propus yet. They've changed on to left lateral. They're still watching. What's happened? No, the baseline's gone up. Baseline's gone up 10. The variability is reduced.
In shadow.
And now we're getting these
Yes.
more chemo. It's very strange behavior. Maybe she's contracting a little bit.
Yeah.
This is a trace where you'd look at it and go, I am not happy. This is 5 o'clock. If I can't get I would do a bedside scan. If I can't, I'm not a sonographer. I would do a bedside scan just for volume. See what's going on. This is supposed to be a big baby. If it's a big baby, what condition might it have on the scale of the hypoxias? If a big baby has outgrown its placenta. May not have forget the diabetes. It may not have diabetes, but if it's just outgrown its placenta, so you can have hypoxemia because the placenta can no longer cope with the size of the baby. And what this maybe is hypoxemia, because here we have a normalish trace with some core compression, but as soon as she seems to be doing some neutron activity, we're pushing this baby a little bit over the edge, and it's just saying to you, hang on a second, I'm not in labor yet, and my heart rate's gone up 10 beats. Where are you taking me? I'm now a heart rate of 150, and I haven't even started induction. Actually, maybe it was breach. And that's why it was decelerating. Let's go back. You see there, she's contracting. So these weren't chemo. They were baroreceptors. They were head compression on a breech baby. So your scan would have been very helpful. You'd have gone, it's breech. And the reason you had big core compression is when it's breech, the cords are there and gets compressed. So, just like everything else, you're not looking at one single piece of information that gives you all the answers. Because as soon as she's, the point is, if you look here, you've got some contractions, and with each contraction, you're getting deceleration. Now, normally, that would be with a low head. But of course, the contraction is happening at the top, where the head is. So with the contraction and not labor, you're getting very early head compression. So look at the traces and just think, I don't like the trace, I need more information. I can't make sense of it. The point is, I'm not relying on pattern, I'm trying to diagnose. What is happening to the baby? We got core compression. Then with this, we thought maybe hypoxemia, but if you look carefully, with each contraction, you're getting a deceleration. And the scan would have given you the answer, it's a breech baby, and in fact, the baby's completely healthy, and there's nothing to worry about. Short and sweet. Section. It's the UK. We knew it was a breech, but it's a large for dates, so you're not going to do a vaginal breech large for dates. Oh, don't start me on how do you know. I get asked medically, is it reasonable to not notice that the baby is not breech until full dilatation? Oh, okay, hang on a second, that's a different story. You can miss it antenatally. You may, often people think that what they think is the head and is high is actually the bum. Sorry, the other way around. They think the head's low and what they feel, and they think they're feeling the shoulders, is actually feeling the bum. That would have been a scan previously, but obviously when it came in, she was breech, so it had turned. It was one of the 5% that turned. Unfortunately, it turned the wrong way, or fortunately. Okay, so another, oh gosh, this is 10 years old. So we were talking about diabetes. Here we have a diabetic baby, or mother, a baby of a diabetic mother. So second episode of glycosuria, 36 plus 5, and the plan was for GTT. GTT was positive, but was controlled on diet. 14th of May, she comes in for CTG because of reduced fetal movements. Here's your trace. So she's, what is she? She's 37 weeks. Something like that. I think she is. Baseline is 140 to 145. The variability is 2 to 5, but it looks like you've got some cycling, doesn't it? So it looks as if you've got good, bad, better. But what do we not have? Accelerations. Therefore, we must continue the trace. Oh, well, there you go. You asked for accelerations, you get accelerations. But you saw before that, you had cycling, so you felt reassured that the baby was okay. And now we have accelerations and a normal trace, and she's going to go home, which she does. So she's seen by the reg in antenuclear at 38 weeks. The fundus was 34 centimeters, but they said normal growth and ultrasound scanned at 37 weeks, and the plan was for induction at 40 weeks. And in those days, our gestational diabetics on diets were induced at 40 weeks. Fetal movements, tick, GBS was found on an MSU and was treated and was seen by midwife at 38 plus 6 and 39 plus 5, and the baby was active and no doubt was going to come in for induction the next day or two. So here's an ultrasound scan that we have. And we can see here they didn't measure the Lycor volume. The Lycor volume AFI was not 0. They just didn't measure it. But we can see here the growth velocity. So the BPD is on the 50th, the head circumference on the 50th, the femur length is on the 50th, and the AC was on the 50th, and is now on the 25th or thereabouts. So there may be some slight tailing off in the growth. So what the registrar missed by saying normal growth and ultrasound, they should have picked up that actually the growth was tailing off. So she's admitted for induction. CTG commenced, but no documentation of the abdominal palpation. And we have a baseline here of 160 coming down to 150, perhaps going back up. Any comments about that baseline? It's a little bit higher than it was previously. Yeah, the week before it was 140, and now it's 150 to 160. 3 reasons: maternal stress, fetal stress, baby infection. It may be that mum's stress. Mum's pulse is 93. She's coming for induction. We'll see how it goes. There's a core compression deceleration. You can see it there on the right-hand side by 11:51. And midwives clearly think that giving water is going to help, so they give us some water, which does nothing. The baseline is still hovering high-ish, 140 to 150, with some core compression decelerations. (12:35), she has a review. No contractions, baseline 150, variability 5 to 15, no accelerations. Single deceleration down to 150, lasting 30 seconds, unprovoked. So what do we think caused that deceleration? Difficult to tell. It doesn't obviously look like cord, but it could be. But the other thing about it is you've got a slightly slow recovery on the second arm. So it's coming down and then slow to recover. It's going back to a baseline of 155 to 150, but then recovers again. So it's a very unusual trace. It's one of the, if you like, uninterpretable. I don't know what's going on. Do I need to worry much? Yeah, it's going back to normal. She's coming for induction. So what I would say these days is I will individualize the care, and I would shorten the interval between CTGs, so I don't make it, yeah. There is no shouldering, you're absolutely correct. So, like I'm saying, I'm looking at it, I'm not saying, well, I'm not sure if that's cord. It may not be cord. But equally, if it's not cord, what is it? I don't know. There's a lot of fetal activity there. The black dots you can see underneath the red line. That could be fetal movement. And it may be that the whole thing is just causing havoc. Don't know. It's one of those where I'd say, let's just keep a closer eye on it, because I really don't know at the moment whether this baby's happy or not. At 13:10, another deceleration noted to 85, recovering in 30 seconds. Variability remains good. To continue. Now these look more like cord. So you've got cord. You can see on the left-hand side you've got cord compression, and that looks like it's going down and straight back up. Remember, the mum's pulse was 93. This heart rate is going down to 80. So it is likely, although we've got loss of contact, to be fetal. Okay, so what do we do? I mean, we can continue, we can stop, we can give up, we can go home. Continue? And then what? For how long? How about an alternative? Deliver. Should you deliver now? On what?
General examination.
She hasn't had one yet. It's a very good question. Do a VE. See where we're at. She's not in labor yet. She's waiting to be induced. She's waiting to be induced. She's waiting to get her propes. Another deceleration. Variability remains good, position changed. What might you do before you induce? We've mentioned it already once. No, before we induce. What else? What might we do? Scan. Get a scan. Do a Lycor volume. Make it almost second nature. If you've got a trace you can't quite get a handle on, you're not very happy, just do a quick scan. Do a quick Lycor volume. See, every labour ward should have a bedside scan that you can just do quickly, get the Lycor volume, and everything's fine. But you can see this baby is not hypoxic. Look at the variability. This baby is not hypoxic. It's fine at the moment, but clearly there appears to be a lack of liquor or cord compression somehow. It was GDM on diet. Yep, 40 completed weeks, GDM diet, well controlled. But, do you remember the scan? The baby's growth was tailing off. And they didn't measure the liquor volume, which was not helpful. So they continued to trace. The baseline is settling. Look at the uterus. It's interesting, isn't it? Why is the uterus doing that? She hasn't had any progress yet. Could be infection. Not sure. More core compression. I don't know what they're doing. They're just keeping this poor woman on a trace. Chewing up paper. No CTG interpretation for 2 hours. But the trace seems to have settled. You've got acceleration. There's a biphasic acceleration on the far right-hand side. So there looks to be core compression. There's uterine irritability of some sort. Don't read that, I'm trying to go back to the last one. There you go. So, at 3:30, baseline 130, variability 5 to 15, accelerations present, possible decels, query loss of contact. Do we think there's loss of contact? No, it's quite clear there are decelerations. Normal to continue CTG. Remember what I said, the one word you shouldn't use in obstetrics? Continue. Because then what? Because then guess what? There's a man who writes in purple, comes along and says, I'm not happy about this. CTG, 135, accels present, 2D cells, suspiciously, seen by consultant for ultrasound scan. Oh, finally, they involve me, we get an ultrasound scan. What does it show? No measurable pool of liquor. What a surprise. Core compression due to anhydramnios, not simply cord entanglement, abandoned induction, convert to cesarean, patient given time to accept decision. Baby was not hypoxic. But there was so much information. You can see that there was enough information on the trace that said, look at the liquor volume. Do not continue with this induction. Yes, the baby's not hypoxic. Yes, the baseline is normal. Yes, there are accelerations. But also, there is cord compression. Why? Look for it. You can see why. Do a scan. There she is waiting. And you can see now, heart rate's gone sky high. Don't know why baby decided to do that. 160. She eventually has a cesarean. You can see more decelerations. It took her a while for her to accept the cesarean. We got there in the end. Thick meconium, no lichal. Baby, 2.4 kilos, much lower than they expected. Remember, this baby was on the 90th centile, allegedly. That meant they didn't measure it. It doesn't mean it's 0. Because they also said the cerebellum was 0.0. So I think it's confusing because they don't measure. If they don't measure it, they put it as 0, which is not helpful. That was my scan. The sonographers, if they see anhydramnios, they write it. They didn't write anything. They just put normal growth. So they didn't measure it. They should have done. APGARs were good. Well, I'm no surprise in the APGARs, 9 and 9, because baby was not hypoxic yet. And you can see the rest of the pHs. Did well after some difficulty maintaining BMs. So, beautiful demonstration of physiologist CTG saying, look closer, don't just assume because of the accelerations that the babies can tolerate labor. Okay, it's 10 to 9. I think most people are tired. Yes? Yes?
Question time.
And I think I will stop there, thank you. Any questions at all about this? As I said, I'm here all weekend. Feel free to come talk to me if you've got any questions you want to ask me personally. But if not, I'd like to thank you. Those of you who are still here.
Mike, I've got a question to you. Do you do a continuous CTG monitoring on all your patients, low and high risk?
No.
No?
No.
Only on the high risk?
Only in the high risk or those who wish it.
Okay, okay,
We have a maternity-led birth center next to us.
okay. And do you send back every patient till they come back in active labor at 4 centimeters?
Ask my midwives. I don't get involved in that. They won't be seen by me. We have a midwifery triage,
Okay.
and if they're not,
Because you send back a patient at 3 centimeters.
the midwives did. I didn't.
Okay.
No, it's all midwifery. So yes, I just want to say thank you very much for your attention, for staying awake, and for Zumbering, and I am very humbled by being here and being able to share my information on physiological interpretation. So thank you very much indeed.
One question, Mark.
Yes.
Have you given up fetal blood sampling in your unit completely, or?
We haven't done a fetal blood sample for at least 5 years. At least.
Good. And when you mentioned about the infection trace,
Yeah.
occasionally patients who have prostaglandins and they have this pyrexia, baseline tachycardia, we find it difficult to differentiate whether it's a prostaglandin-induced fetal tachy or if it's an infection. There's no way we can separate the two. Most of them would have had prostaglandins.
The one thing you can look for in those cases is look at the white cell count and the CRP. The CRP won't be raised if it's prostin, or won't be as raised. But I agree, it's difficult.
Thank you.
Yeah, I too have a question. When we said that fetal scalp stimulation followed by acceleration, do you mean that we need to document on CTG or just with the handheld Doppler?
What you should document on the CTG with a line is your V. It becomes very obvious. You don't need to then write fetal response.
Right, but whenever...
But if you're then doing a CTG interpretation in the notes, then you should put in the fetal response.
No, my question is, whenever there
Oh,
is
no
no
CTG.
CTG, if I am doing a PV examination, do you think it's worth at the same time we put a Doppler and say that there is acceleration?
I don't know anybody who will do auscultation and a V at the same time.
See,
No?
there is a dop tone so that you can hear the sound.
Yeah?
Yeah. Or if the CTG is on, of course we will hear it.
No,
with
but
the dop tone,
you're doing, well, we use sonic aid, so
Sonic aid,
yeah, same thing.
sorry.
But would you hold that and do a V at the same time?
Whether we can adapt.
No, I understand. I'm saying I've never seen it. I think it's very innovative. Why not?
No, we do that.
Usually we don't do continuous CTG for everyone. Rather we opt for doing intermittent CTGs and otherwise intermittent auscultation.
Okay,
So
you've just committed a
So when a
heinous
patient
crime
is
of intermittent CTGs. Never. Medical legally, you will hang yourself. Never, ever, ever do intermittent CTGs. You either do intermittent auscultation and you accept the limitations, or you do a CTG. If you do intermittent CTG, all you're saying is that whilst in that time, it's okay. But you've got no idea what happens in between, and you are perhaps falsely reassured by the CTG trace.
That's what Serena asked you.
Yeah.
Whether you do a continuous CTG in labor.
When she said for everybody, I said no.
Sorry?
She said for everybody.
Yeah,
Her question was, and everybody know.
If you are doing it, do
Once you start, you don't stop in labor. But you do not do it. I would never recommend intermittent CTGs. No, I said. So I think your question was, do you want to check the baby's response when you do VE to confirm that you've got an acceleration? Yeah, absolutely. I think it's brilliant. So you can do that and go VE, acceleration heard during VE, reassuring.
The reality in our country is that we cannot afford to have CTG,
No,
even for those whom we feel like. So many labor rooms have one CTG machine, at the most two, and so they change. Once you see acceleration for about 10 seconds or 10 minutes, and then they disconnect, go to somebody else.
I think then you accept the limitations of the use in your country, which is
That's
and that's fine
right.
because it's whatever your standard is.
That's right.
Yeah.
That's how it is. That's the reality. I hope all of you will agree that it's a demonstration of stamina, not only of knowledge. Thank you very much, Mark, for
Thank you.
sparing, staying on this late, and of course bringing in the Zumba and all that. Okay,
Yeah.
that brought in diversity.
I'm not bringing in Zumba again. That's
Yeah.
dangerous.
Okay, thank you very much. Thank you, Mark. As you said, we will be seeing you again over these days.